So the YouTube link is live now. So I think we can just begin.
Yeah.
A very good afternoon to all of you. On behalf of Department of Medical Education at AIIMS, we welcome all the participants and the resource faculty for the webinar. The topic for our webinar today is Quality Improvement, a New Paradigm in Healthcare. This webinar shall not only talk about quality improvement, but how to publish the work that you have done and more. We have with us, we are very happy that we have a very esteemed faculty from different corners of India. We have faculty from AIIMS New Delhi, faculty from Chennai, from Government Medical College, Chandigarh, and PGI Chandigarh. So we'll have them all sharing their experiences regarding quality improvement, because these are the faculty who have hands-on experience regarding quality improvement. We are also very happy to announce that we have more than 700 registrations for this webinar,
Great.
which is very encouraging for all of us. And this 29 September 2022 also is a landmark day for the medical education unit at AIIMS, because here we embark on a journey where we have started the educational webinar series. The first in this series is the quality improvement webinar that is being held today. And we hope to see all the participants who are here in future too along with us, and even more, maybe all your colleagues will join us. So before we begin the webinar, let me introduce to you Dr. V.Chauhan sir. He will be introducing quality improvement to us. Dr. V.Chauhan sir, he is the Pro Vice Chancellor of the university, and he is also a FAMER Fellow. He is currently heading the Department of Orthopedics, and he has fellowship from the AO. He is also recipient of several national awards and honors, and is associated with building the institution since 1994. Even he's one of the founder members of this institute. And even before people would talk frequently about medical education, he was the person who actually initiated medical education at AIIMS. So under his guidance, the department has flourished. And we hope that under the leadership of Dr. Ashok Deorari sir, more such initiatives shall take up. Over to you, sir.
Thank you, Dr. Juhi. Very good afternoon, everybody. I'm audible, Dr. Juhi?
Yes, sir, you are audible.
Good. I take this opportunity to welcome Professor Dr. Deorari, our Principal, Himalayan Institute of Medical Sciences, Professor Praveen Kumar, Head Neonatology, PGI Chandigarh, who is the moderator of this session today, Professor Akshay Kumar from Emergency Medicine, All India Institute of Medical Sciences, Delhi, Professor Parijat Chandra from RP Center AIIMS, Dr. S.Sindhu, consultant from Cloud9 Hospital, Chennai, Professor Aparna Sharma from the Department of Obstetrics and Gynae AIIMS, and Professor V.Chauhan from GMC, Chandigarh. I'll be just introducing the subject so that all our participants, then they can follow what our faculty members have to say about it. I think quality is a buzzword from the time we all get up early in the morning. I think the first thing which you do, you go to the bathroom and you see the paste which you have, toothpaste, the toothbrush, the shaving cream, then the fruits you have in your breakfast. Everybody starts talking about quality. So what exactly are we talking is, quality refers to a set of characteristics expected from products or services. In fact, it is a combination of various factors such as design, performance, reliability, safety, efficiency, effectiveness, economy, and timelines. Friends, the methodology of improving quality in healthcare has evolved in the last decade tremendously. And there are several factors which are responsible for it. One, the large number of field experiences coming from the worldwide and in different specialties in healthcare delivery. In this session of ours today, we'll be focusing more on the health systems qualities. Two, the increasing complexity of healthcare delivery, and with that, the emerging new needs for efficient and cost-effective care. Third, the increased expectations of our customers, of our patients. Patients are our customers. And the advances in knowledge on improvement, management, and clinical practices. These all factors are responsible for quality, for making us drive for quality improvements in healthcare. Friends, quality improvement identifies where gaps exist between services actually provided and expectations for services. It then lessens these gaps not only to meet customer needs and expectations, but to exceed them and attain unprecedented levels of performances. Quality improvement is based on few fundamental principles of quality management that focuses on the client, systems and processes, teamwork, and use of data available with us. Originally, improvements were thought to depend on adding a new machine or a procedure or training or supplies in the health industry. It was believed that more of these resources or inputs would improve the quality. But this is not the truth. People realized that increasing resources does not always ensure their efficient use and consequently may not lead to improvements in quality. So in order to benefit from the machine's advancement in technology, we also need to work with our systems. Employees need training. Patients need access to the services. And system of healthcare delivery must be changed in ways that permit the use of this new technology. Improvement involves not only adding new resources to a system, but also making changes to an organization in order to make the best use of resources. Improving the processes of healthcare not only creates better outcomes, but also reduces the cost of delivering healthcare. I think in our medical education, since we all are doctors sitting here and talking, we all learned about systems approach. We have an input, we have a process, and an output. And based on our output, we give feedbacks and we make a change either in the process or in the inputs. If you make your changes in the inputs and processes, believe me, we'll be doing a human service to humanity. Friends, this seminar is an update on quality improvement methodology, which incorporates the most recent thinking on how to implement improvement. We have a learned faculty with us today from various national institutes. They would be sharing their experiences, how they made a change in their systems where they are working. I think with these introductory remarks, I hand over the mic to Professor, to our moderator, and the next speaker, to the moderator. I think the moderator can decide for. Thank you, sir.
Thank you. So very good afternoon to all of you. And first of all, my heartiest congratulations to the Himalayan Institute of Medical Sciences, Swami Ram Himalayan University, for taking this initiative of starting a web series. And special thanks to Professor Juhi from the medical education unit at the back end for planning and organizing and executing everything flawlessly. I think the topic chosen for the first webinar series is very apt. And we, as Dr. V.Chauhan, laid the foundations of why quality is so important to us, whether in general life or in healthcare, and more so in healthcare these days. So after he laid the foundations, I think it's very critical now we look at how it can be implemented. So the plan for the day will be that we will have an introduction to QI for residents by Professor Deorari. Then we will have 4 presentations by very experienced people, clinicians, who have actually executed quality improvement in their respective areas and respective departments. And after that, at the end, we will have a presentation to tell us how this work which we are doing for quality improvement, how it can be published and also give us credit and also can be shared with others. Now, why choose residents as the target group? It's understandable because when we started looking at quality maybe 10 years ago, it was all new to us. So it's very difficult to teach and train people who are working already in a particular manner. So very difficult to change. So if we target the freshers who are just entering the post-graduation or maybe MBBS, similarly in the nursing, BSc nurses or the MSc nursing. So if we can target them right at that moment, train them in these, I think then the impact is going to be long-lasting because wherever they go, they work, they are going to carry this culture with them. And also by experience, what we have seen when we involve these people, the residents and the nurses in quality improvement, they are really excited. I think otherwise, when they are so much overburdened with day-to-day clinical work and everything, this gives them a lot of satisfaction and happiness because they see they can, make a change and they can see the effect. And they are our frontline team. They are the ones who can come out with actual good change ideas that we'll learn later on. And hence involving them, I think, is a win-win situation for the whole system. So I would straight away invite Professor Ashok Deorari. I think everyone knows him. He is kind of, I would say, the father figure for quality improvement in healthcare in India. And he's so passionate, so enthusiastic. And I think his energy is always infectious. And wherever he has gone and done workshops, and now after joining this new institute, as you can see, straight away he is on the job and involving everyone and spreading the word of quality improvement. So over to you, Professor Deorari, for your presentation.
We cannot hear you, sir. You are muted, sir.
So good afternoon. Thank you, Dr. Praveen, Professor Chauhan, our Pro-Vice Chancellor. And I'm so happy that on behalf of Himalayan Institute of Medical Sciences, we are conducting this first educational webinar with learned speakers who have hands-on experience on doing quality improvement work and faculty who has had multiple publications by doing quality improvement work. Let me welcome all the faculty members from different medical colleges who have joined today, the nurses and the resident doctors who are the frontline health workers, even the paramedic workers or allied sciences students who have joined today, because the quality improvement work relates to each and every individual in each and every sphere of life, as Dr. Chauhan has mentioned. I am going to focus my presentation over next 12 minutes on, first of all, share with you what is quality healthcare, what is quality assurance and quality improvement. The reason for that is I have found a lot of people confuse quality assurance with quality improvement in healthcare. The definition of quality healthcare is laid by Institute of Medicine way back in 2001. They laid down that there are 6 dimensions of high quality care, and it goes with a mnemonic: STEEP, S stands for patient safety. First, do no harm, no medication error, use checklists for performing procedure. T stands for timeliness. Timeliness means the patient is seen by a right clinician at the right time. E stands for efficiency of healthcare. That means we need to avoid waste of resource, time, and money, and provide cost-effective healthcare. Second E stands for equity of healthcare. It means irrespective of gender, irrespective of religion, rich or poor, everyone must get high quality healthcare. The third E stands for effectiveness of healthcare. That means best practices which are evidence-based must be applied for management of any clinical condition. And then P stands for putting patients at center of healthcare. That is so important that we must always keep in mind that patients must have a good experience of care while they are visiting the outpatient or they are admitted in the hospital. World Health Organization in the year 2014 made a global framework and laid down the standards for quality of care for mothers, newborn children, and adults and geriatrics patients. According to this, they also said we must have skilled healthcare professionals manning the healthcare facilities, and they must be competent enough, and the healthcare which we provide must be provided, especially for a woman who is delivering in the labor room, with privacy and confidentiality. Quality and safety in healthcare are in focus globally. Globally, while I say, World Health Organization also gives a huge importance to quality and safety in healthcare. There are two important pillars which determine quality of healthcare. One of them is called as quality assurance. The second one is called as the quality improvement. Quality assurance relates to infrastructure, standard operative procedures, manpower, and normally quality assurance is done in periodic basis by accreditation process, and it is a top-down approach. The feedback is given to the MS, to the director, or to the principal of the hospital. Government of India has laid the NQIS, National Quality Assurance Standards, which were laid in 2013 and revised in 2016 for public health facilities. The second piece is quality improvement, which relates to improvement of processes of care for better outcome. This is in the hands of frontline workers. It is a continuous process of quality improvement, which the healthcare workers have to learn. And then it is a bottoms up approach, because the frontline worker, the nurses, the resident doctors, and even the OTA staff, they know what the problems exist in the health system. The National Accreditation Board of Hospital Accreditation Criteria addresses the process for quality assurance and even advocates use of checklist, but it does not address the process improvement, which has to be done by frontline workers by doing measurement and then taking action by making a team of healthcare professionals, and in the team are the faculty member, the resident doctors, the nurses, even the sweeper and the family are there in the team. So while we are talking of quality improvement, we are talking of a proactive approach, and in this approach, we need to improve the processes and the outcomes, often using systems approach. And this uses plan, do, study, act cycle. Just to give you example, if we have to do hand washing for a particular duration before entering ICU, that is a process of care, doing it in the right manner for the right duration. And the outcome for that is the rates of nosocomial infection which will occur in the ICU or in that particular ward. On the other hand, having a running water, soap, and a SOP and a poster at the place where hand washing is being done is coming under quality assurance. So you can see quality assurance and quality improvement go hand in hand, They are two sides of the same coin. But remember, to run a health system, in addition to these two important pillars, you need supply chain, you need money, you need data which has to be collected on regular basis, key performance indicators which have to be collected so that action can be taken in that particular healthcare facility. Now, as a doctor or a staff nurse or a OTA, you will ask me, why should we learn about quality improvement? All healthcare professionals need to understand that if you start using quality improvement in your day-to-day practice, you become a good leader. You become a good team maker. And as you work with a team, you always look at avenues for making improvement, the problems which are there existing in the health system. You will be able to see while you are doing quality improvement that the improvement occurs in front of you. It gives you immense joy and satisfaction. As you will hear from the experience of the next speakers, it adds value in healthcare. It leads to better patient care experience. It saves money, resources, and even waste of time in the outpatient and operation theaters can be reduced if you use quality improvement approach. For a healthcare professional, it builds leadership skills. They learn team building. They learn how to collect and measure data. They also learn how to put the data into use. In addition, while they share the success stories and publish, it gives them internal motivation to do more and more work, and it gives immense joy and satisfaction. On the right side is one of the publications we did in 2018. It has 20 stories of quality improvement work which is done in the country. For a resident doctor and for MSc nurses who do dissertation or thesis, you can do a quality improvement work as a dissertation or a thesis. You can publish it in a journal. You can make a presentation in national, international conferences. It counts for professional growth. As I know, in annual appraisals, especially in Western countries, you don't get promotion unless you are doing quality improvement work for that particular hospital or for that particular setup. It addresses medication errors, safety issues, and it also leads to better experience of care, and then also avoids underuse and overuse of treatment in healthcare facilities. A lot of people want to compare quality improvement with research. I would say quality improvement is implementation research, which is being tried in Indian context in that particular healthcare facility. So quality improvement, the intent is to improve the current practice. You want to make implementation of best practice. There are reasons they are not getting implemented. The results are instantaneous. It is context specific. And then most of the time you don't need IRB approval and low cost. You can do the quality improvement within the existing cost. You don't need money or resources for doing. Only thing what you need is a good heart and a brain, and then your hands will do the good work for doing quality improvement. On the other hand, in research, you write a protocol. It is all fixed. You can't change it. You can't get the results till the end. It needs money. It needs IRB approval. On the other hand, while you are doing quality improvement, it is done in small steps, and you can keep on changing whatever PDA cycles you want to do. Now, let me come to the science of improvement, which is simplified, our Indian model of POCI approach. So I can tell you at this point, there are 5-6 models of quality improvement which are getting used. Many of them are used in industries also. One of them is Six Sigma technique, ISQA technique, or an NHS UK model of quality improvement, or Institute of Health Improvement model of Cambridge, Boston. We have in India an Indian method, which is called as a 4-step approach, a POCI approach, POCQI, which is called as point of care quality improvement methodology. Goal of these all methodologies is same. They want that implementation of best practices and processes has to happen. And then we have to have improvement in processes of care so that we are able to provide timely care to our patients. So as I said, we have in India a 4-step approach, and there are publications on that which are there on the web, and it uses a PDSA cycle. And the best part is it uses a 4-step approach. And in each 4-step, again, there are 4 key areas to focus. Step 1, which is identifying a problem. Step 1, forming a team, prioritization, which problem you want to settle, and then making an aim statement that you want to improve some problem from what point to what point over what duration. So there are 4 points in step 1. Step 2 is you use tool to analyze for the problem, and then you have measurement which has to be done. For analysis, you use 4 tools which are used commonly. You will learn, people use that. One of them is called the fishbone analysis. The second one is called as the process flow. The third one is called as a Pareto chart. And the fourth one is 5 whys. And for measurement, you have to have a numerator, you have to have a denominator. And for demonstrating that, you have to make run chart. Run chart is X, Y, X. On the X-axis is the time. On Y-axis is your variable which you are going to show. And run chart and control chart you draw. And in step 3, again, there are 4 things which you do. PDSA, plan, do, study, act cycle. So you use PDSA cycles, multiple one or single one, adopt it, adapt it, or abandon it. And then you sustain. And for doing sustenance of quality improvement work, before you embark into next quality improvement project, you have certain methods. Again, there are 4 key points for that. So as I did PubMed search recently, I looked at using the keywords of quality improvement, newborn, mother, child, emergency, ophthalmology. Then I found there are nearly 12,000 publications which are there on the PubMed. And then while we did this for India, we find there are nearly 390 publications which are there. And once we are doing a search for POCI, point of care quality improvement for the global one, we are getting a number of nearly 659 publications. So these are few areas which come to my mind, which are for hospitals, which can be taken for quality improvement. In addition to quality assurance work which happens with the NABH, reducing waiting time in OPD in a scientific manner, improving patient experience with OPD consultation, how you can have better consultation, discharge a patient on right time from the hospital, tracking key performance indicators for improvement, post-operative hospital-acquired infection, urinary tract infection after urinary catheterization, ensuring surgical safety checklist gets implemented in the OTs, and then improvement audits for less common events like near miss and mortality, and so on. You can build this list more and more. My request to everyone is we should demystify and teach and practice and learn quality improvement methodology. It is everyone's responsibility. It is not of faculty members or the dean or the principal or the MS who will know. These are management principles, not taught in medical and nursing and paramedical curriculum. So hence it becomes all the more important that you learn the quality improvement methodology. Thank you. Over to you, Praveen. If there are any questions, I would be pleased to take them.
Thank you, sir. Thank you very much. The audience, if so far we have not received any question, but the audience is requested to keep posting questions. Now, before I comment on, maybe I can give some summary. So I think 3 or 4 key things which emerge from Dr. Deorari's presentation. One is that in our country, we have been obviously doing so-called quality assurance and accreditation. So we have quality cells at each district, but they are all looking at NABH or NQAS or some other kind of accreditation. There has been no kind of effort to find out, okay, how do we bridge the gap? And that skill has been lacking even in the quality managers so far. And typically, I think this job has to be of the clinician in combination with the administrator, because clinician is the one who can understand what are the bottlenecks and what are the real gaps and how it can be improved. So that was one important key point. The second, Dr. Deorari told us that we have to measure both process and outcome. So the way we are doing things, which is resulting in an outcome. And if you go around and look in your own hospital or ward, we will typically find that the process itself is so variable. For example, simple thing, inserting an IV line. You look at 10 nurses or 10 residents, everybody may be doing slightly differently. So the first job is to somehow standardize the process and then also obviously try to make it more efficient and try to improve it further. Dr. Deorari also mentioned that you need some soft skills also when you're trying to embark on quality improvement, whether it's teamwork or collaboration or open-mindedness. Like it should not happen that the frontline resident or nurse is coming and pointing out something which is wrong, and then the person is dismissed that you don't know anything. This is our typical response. So we have to listen to the frontline person, and ultimately we have to also question ourselves. Who is the one who will decide what is quality? So Dr. Vijender gave an example of going to market and buying, let's say, television or car or some such thing. So we decide what is a good car, what is a good TV. So similarly for us, it is our patient or the family. They are our clients. So they are the ones who will tell us whether our quality is good or bad. Often we dismiss them. We say patients don't know anything, families don't know anything. But we have to change our mindset. I think they are the ones who will decide whether we performed well or we did not perform well. And Dr. Deorari referred to the POCI website. So I think it's a beautiful website. If you go on it, you can do an e-course of maybe within 2 to 3 hours, an overview of the 4 steps of quality improvement. But obviously, if you attend a full 1 day or 1.5 day workshop, that will be great. And that can really empower you, give you certain skills, which you can utilize on your setup. So before I still don't see any. Yeah, okay. So Dr. Deorari, there is one question for you. How do you address the behavioral challenges in QI? Because typical complaint is, I am doing my best, but my co-workers or my colleagues or juniors, they are somehow not cooperative or they don't participate in this. So how do we change the behavior, or what is the approach?
I think whenever you start doing quality improvement work, you make a team of like-minded people who work together, embark on the journey of doing a quality improvement work. Maybe at one point of time, you will have only 20-25% of the people who want to do it. Not everyone will be with you. Once you start collating the data, it should start showing you improvement. You show the run chart. More and more people will keep on joining you, more and more people, because they are waiting for data to be seen that this is what improvement is occurring. So this is how quality improvement works, picks up. And maybe at one point of time, you will have 75 to 80% of your healthcare professionals, doctors and nurses, faculty, and everyone on together on board. There will be 15 to 20% of people who have abnormal behavior. They are late laggards. There is no point in spending time on them that you want to make improvement. They are born with that. They will keep on smoking in a room and have coffee, keep on criticizing because God made them like that. And there is a principle in healthcare. If you reach 80% and create a culture of 80% in healthcare professional, your results are going to be world-class type. This is for even hand washing compliance. If you get about 80-85%, you don't have to strive for 100% compliance for hand washing. And even for measles vaccination in community, if you reach 80-85%, you don't have to vaccinate 100% of the children for measles protection. Praveen, I hope it answers the question. Don't focus on late laggards.
Thank you very much. I think it's wonderful. And I think it's our own mindset also. We have to accept people as they are. Don't try to change people, change the system so that they will be forced to work the way it should be. And as Dr. Deorari rightly mentioned, focus on those who are interested, take them along, and gradually the team will automatically, keep on expanding and more people will join. So very important question from S.Sindhu, Bihar, Dr. Deorari, for you, from Dr. Sanjay Kumar. I think you also mentioned that we do need the supply chain and structure, etc. So he's saying that in SNCUs, we don't have sufficient number of doctors and staff nurses. So And the quality depends on manpower too, as you rightly said. So can we really do quality improvement in these setups, or we have to wait for the full manpower to arrive?
No, I think you don't have to wait till you have the palace which is created or till you have everything. Quality improvement can be done within the same resources and existing system. And you will hear that from many of the team members. And this is our belief is also, you don't have to wait for entire completion of, I have to have 100% nurses, 100% doctors, then only I'll start improving my system. I think there are small bits, Praveen, you can still improve on that, Dr. Sanjay, and then keep on learning the science and the art and the practice of how quality improvement work is. Because if you keep on doing more and your administrator come to know that you are doing quality improvement work, you have run chart with them, you show it to them, they will give you more resources, more nurses, more staff, and more supply chain, more money, whatever you are asking. So I think it is all interwoven, and we should not have that impression that you have to have everything and then only you will do quality.
Thank you, Dr. Deorari. And I think this is actually also proven by our collaborative experience from the state of Madhya Pradesh over the last 5-6 years. And you can look at one publication in BMJ Open Quality 2021 by Jai Singh Parmar from SNCU Dhar in Madhya Pradesh, where it was shown that within the same manpower, same resources, they were able to decrease the use of oxygen dramatically. And they made a lot of saving, nearly 60% of annual budget was saved, which was then plowed back to buy more pulse oximeters. So actually by using quality improvement, you may find you can eliminate a lot of waste you're doing, whether it is unnecessary IV fluids, unnecessary antibiotics. So you decrease the work of the existing manpower, and it will generate more time available for them for doing, extra work. So don't wait for, till I have more manpower. You try to look for waste and try to eliminate that. One more paper which is about to be published, I think within the next 7-10 days, which is the complete paper from the Madhya Pradesh experience. Look for a paper in the Global Health Science and Practice Journal from Boston University, which will talk about and explain all these, bottlenecks and how they were overcome in Madhya Pradesh. I think this is a very, very replicable model. Dr. Deorari, there's a question, one more last question for you. That do we need to send to ethics committee for approval before we start a QI project?
So majority of the quality improvement work which you do, if it is not involving human subjects, then there may not be a need to get to the IRB for approval, but it is always better to inform your IRB, because once you go for publication, they will ask whether you have taken the IRB approval or not. So it is a fast track thing which can be done. Also keep in mind, if you are having human subject or you are testing some intervention which is getting tested, or you are taking patients' consent and confidentiality has to be maintained, that has to be brought to the IRB for getting a IRB approval. Because unless you do that, it is not going to get into publication.
Do plan to publish. So it's better to err on the safe side, take the approval. They will give fast track. In case you're planning to collect some extra data, which is not being collected routinely, then it's obviously mandatory that you do take a ethics approval. So thank you, Dr. Deorari. This was a wonderful session. And before I invite Akshay for the next talk, I think Dr. Juhi wanted to formally introduce you, which got missed. So over to you, Dr. Juhi.
Thank you, sir. We just heard Dr. Ashok Deorari, sir, the Dean and Principal of AIIMS. He has vast experience, as you must have gathered from his talk, in QI, and he has been the head of WHO Collaborating Center for Training and Research in Newborn Care at AIIMS Delhi. He has been the ex-chairman of the Skills Center at AIIMS and a lead faculty for QI WHO CRO, short-term consultant there. And he has several publications to his credit. Thank you, sir, for taking QI to the next level by introducing it to our audience. But before we proceed further, I would also like to introduce Dr. Praveen Kumar, sir. He would be the moderator of the session today. Sir is heading the Department of Neonatology at PGI Chandigarh. He has several publications to his credit and several book chapters that he has written. Sir is also the honorable member of the American Pediatric Society and the ex-visiting professor, University of Toronto, Canada. His areas of special interest are quality improvement and patient safety, healthcare-associated infections, retinopathy of prematurity, and neonatal hyperbilirubinemia. I'm sure there are so many more feathers to your crown, sir, which we cannot enumerate in a short time. But over to you for the webinar. Thank you for moderating the questions, sir, and accepting to be the moderator. Over to you, sir.
Thank you, Professor Juhi. So now we will have 4 presentations based on practical experience. So first one will be by Dr. Akshay Kumar. He is going to talk about improving things in the emergency scenario. You know, emergency is possibly the most difficult. Can we have a first slide, Akshay, so that I can give you some? Yeah. So Dr. Akshay Kumar is additional professor in the Department of Emergency Medicine at AIIMS Delhi. And you can imagine that, you know, and his areas of interest include triage, quality improvement, biology and clinical tools for sepsis. And he has a lot of achievements, including protocol development, large validation study, and he has led several QI projects. He's also leading the acute critical care course training for over 1,200 doctors and nurses for last 8 years. So over to you, Akshay, for sharing with us your experience from the emergency. Dr. Akshay, you can unmute yourself.
Hello, sir. Can you see my slide?
Yes, slides are visible. You are visible. You are audible.
Thank you. Thank you so much, sir, for having us. Thank you so much, Dr. Deorari, for inviting me and giving me this opportunity to share our work in the emergency department here at the All India Institute of Medical Sciences at New Delhi. I'd start by saying that quality improvement started when I attended this very short workshop. It was a 3-day workshop which I attended, and Dr. Deorari was also part of the team. He was more than he was motivating us all the time. And since then, it was early 2017, and it is only 5 years that we've been doing this work and just taking this forward and really enjoying the journey of quality improvement. So I'll kick on with some of the important work which we have done in quality improvement in our department. Just let me give you a briefing on our department. So this is a very high volume emergency department. We have 400 to 500 patients attending to the emergency every day. There is literally no space. There are patients waiting outside the emergency department in queues at 10 in the night. It is normal to see 50 patients outside the department at any given time. So this is a very high volume emergency department. And I mean, thinking of improvement was in itself a big thing at that time. So that's how we started. So we looked at, so I was very lucky. I got a lot of senior support. We had Professor Bhui, Professor Agarwal, who are our key guides, and who we looked at some of the key things which we really wanted to improve. So we identified gaps, and we looked at key performance indicators. So we looked at crucial key illnesses like life-threatening illnesses like sepsis, ST elevation myocardial infarction, like door to first medical contact time. These were the things which we looked at because we thought these were the important key performance indicators for any emergency service. We generally looked at forming teams and empowered nurses, and these were kind of some things which we wanted to do, and we tried to do over the next few projects which I'm going to share. So we've already discussed the point of the 4-step methodology, which was shared by Dr. Deorari. Step 1, step 2, 3, and 4. We used a POCI point of care methodology for all our projects. So going on to the first project which we did, this project we did in 2018. And this was about improving the triage system, thereby reducing the door to first medical contact time. These are patients who are waiting outside the emergency department for hours together. And we really wanted how we can, fast track and see them quickly, because there may be a patient waiting outside, he's short of breath. There may be a patient in chest pain waiting outside who may be having a life-threatening ST elevation MI. So we wanted to look at how we can improve that. So just to give you an idea of the problem we were facing, this is the queue at 10 p.m. And this is usual. I mean, this is usual to see a queue of that 50 patients outside the emergency department at any given time. So what was the process? The patients would first be seen in the triage room before they, after they are in the queue, seen in the triage room. They would then get to the registration counter. After the triage, the resident would send them to the registration counter. They would then be transferred inside. After a brief assessment in the triage room, they would then be sent to the treatment area, which is inside the emergency department. The treatment area is about 100 meters from the triage area. So we did a system analysis. We formed a team of doctors, nurses, healthcare professionals, health assistants who are pushing and pulling the trolleys. And we sat down and we thought, how can we improve the system? And we tried to simplify. And this is a chart of the flow chart of what we really wanted to do. We wanted to fast track some of our patients. The patients of acute coronary syndrome, or ACS, that is any patient suspected of ACS or suspected of stroke, would be fast tracked directly to the treatment area without having to go to the registration counter. Sending them to the registration counter would waste about 10 or 15 minutes. So we wanted to avoid that. And that's how we planned it. So that's what we did. So from the triage, the patients would go directly into we would give them a triage slip rather than sending to the registration counter. The resident would quickly fill in the triage slip with the vitals of the patient and a date and time, and send the patient in through a fast track route, which we also developed, which is so as to streamline patients and fast track the movement of the patient into the treatment area of the emergency department. So that was the triage slip we used. Simple, basic, so that all of them can be easy to do. And that was a red corridor, which we developed, a fast track corridor. This was all done as a part of the first quality improvement project, which we did, is to reduce the door to first medical contact time. If we wanted to improve the, reduce the door to first medical contact, we had to decongest the triage as soon as possible. And the only way to decongest the triage was to improve the output from the triage. And that's how we developed the idea of red corridor and, skipping the registration. And this idea of, clearing the route was actually given by one of the health assistants. Actually, these were the boys who were pulling and pushing the trolleys. So we developed a red corridor, and we asked the patients not to put their trolleys on one side, and the patients could be shifted directly inside to the treatment area as soon as possible. So what were the change ideas? Simple change ideas. What we did was, skip the registration counter, developed a fast track corridor, orientation session. So we had an orientation session. More than anything, we had these meetings, which was attended by all cadres, HAs, nursing staff, doctors, faculties, security guards, sanitary team. So that they are all in the same room, and we just have an open discussion on how we can improve things, make them feel part of the team, trying to change, the culture of how things were. Listen to them, listen to their problem, and try to solve them. And simple change ideas like doing orientation sessions, training the nurses, residents, reducing the nurses' rotation. So what we did was, the nurses were randomly allocated in the triage. So all the nurses who, they were randomly put, every day there was a different nurse. So we spoke to the nursing supervisor and we fixed the nurses in the triage area. So those nurses would stay there for at least 3 to 4 months. And then all the nurses would not change in a single day. They would be changed in a phased-wise manner. That is, 3 nurses would first go, 3 new nurses would join, and then 3 by 3 new nurses will keep joining the triage team. So that is why every time we do training, the triage team would change, and that was a big problem. So we reduced the nurses' rotation, and similarly removing duplication of documentation, and reducing rotations of healthcare assistants also we improved and somehow managed to reduce. So these were some pictures of, triage course, which we organized, first responder course for motivation of the staff. We introduced a new printed triage book, and we managed to reduce the door to first medical contact time. This is a run chart here on this slide. As you can see, on the x-axis is the timeline. So the data collection was started in the April of 2018, and it continued until the October of 2018. There were a lot of hiccups initially when we were doing the baseline assessment. And on the y-axis, we have average waiting time to triage in minutes. And in the captions in the small boxes, we have the change ideas, which we introduced one after the other in order to make an improvement in our system. So that was a very satisfying project which we did. Thankfully, we managed to publish it. Importantly, the second and the third authors on this paper are nursing staff. They are nursing officers. Mr. Dinesh Babu and Mr. Nidesh Joshi are senior nursing officers in the department and were leading the triage, the quality improvement project, and were rightly the part of the author team as well. So, triage protocol was implemented, staff was fixed, fast track policy for acute pain and acute stroke patients was made, dedication patient care coordinator were then introduced. We updated the register. So lots of other benefits happened, and we managed to improve the culture of the place. I'd like to share my second project, which was given as an MD thesis. I was the chief guide, and this was my first candidate, and I asked her to take up a quality improvement project. We identified, again, one big problem was sepsis care. We wanted to streamline sepsis care. The problem was that the antibiotic time, door to antibiotic time, was too long. Patients were not being identified. Sepsis patients were being lost in the queue. And there was a large delay in giving them antibiotics, and also poor blood culture rates. The blood cultures were not being done in time. So we looked at that, formed a team, and that was a team. On the left, you see Charu. She was a PG resident who led the program, who led the QI project, and the team of nursing staff and some of the NIS, which are the nursing information system. They are the emergency nurse coordinators who help in allocating patients to the doctors and help in overall coordination of care in the emergency department. So we looked at the processes very meticulously. We looked at the journey of the patient in the emergency department, patient getting a trolley, coming into the triage area, assessed by the nursing staff in the triage area, and then by screened for sepsis, and then moving on into the treatment area. So that was how we analyzed, and we identified some bottlenecks. We identified that there was no sepsis screening tool. The patients were being missed. Sepsis can present in very subtle manner. So we identified that sepsis patients were being missed. We identified that there was no sepsis bundle in place. Even when the patients were identified, antibiotic, fluid, blood culture, lactate levels were not done in time, and blood culture bottle availability was also an issue. We did another kind of analysis, which we looked at the fishbone analysis, problems which were related to people-related problem, process-related problems, and other problems. So a lot of change ideas we brought in. We looked at a novel sepsis screen. We looked at so what we did was we had this change idea of on-site awareness and training, because emergency staff, they work in shifts. They are not available. They don't come for classes. It's very difficult to organize formal training, formal classes for them. So we developed this 10-minute teaching thing where we would go in the morning, 7 a.m. to 8 a.m. in the morning, and we would just give 10-minute, teaching session for them. So these are some pictures of these teaching sessions. It would be just standing, 7 a.m. where the emergency would be quiet and hardly any patients. So we'd do a quick session. We would take our laptops and show them some slides on the on the laptop, and just talk to them about sepsis, why we are doing this, what is important, how we are doing it, and that those are some glimpses of the on-site training sessions, which was, I think, a very important and played a crucial role in improvement. We obviously had this sepsis checklist which we developed, which was once the patient is identified, what do you do? And we developed a novel sepsis screen. That was, I think, the key change idea in this project. There we developed an AIIMS sepsis protocol. So this was the sepsis protocol, where any patient who was triage read based on the vitals on the left column with a criteria for infection, which is in the right column. So if any patient with fever or headache, cough with sputum, dysuria, reported skin infection, or referred for specific infection, for example, had a chest X-ray from outside with a pneumonia, or had a ultrasound from outside showing a liver abscess. So all those patients were then labeled as suspected sepsis, and we would mark their registration paper as suspected sepsis. Suspected sepsis patients were then shifted inside in the treatment area, and that was a checklist which was used, simple checklist which we printed off. And the first thing we made is that a patient should be discussed with the senior resident. Senior resident on floor should be informed before starting antibiotic, because junior resident should not be starting antibiotic. Otherwise, there will be a misuse of antibiotics. So that is something we wanted to ingrain in the system. Draw blood cultures, prescribe the antibiotic, measure the lactate level, and administer fluids. And that was a simple checklist which we developed for implementation on the floor once the patient reaches the treatment area. That was a run chart of this project, door to antibiotic time. And as you see, it started to reduce during the intervention phase when the sepsis screening tool and a teaching program and checklist were introduced in the system. The blood culture rates started to improve. There was hardly any blood culture sent before antibiotics were prescribed, before we intervened. And right now it is more than 70% that at times that we are doing blood culture collection for these patients. We were lucky to publish this paper in the BMJ Open Quality, and again, as you can see, some of the nursing staff were part of the team as co-authors. Also, were also part of the team of this project. My third important project, which I'd like to highlight, was also given as a thesis project. This was done by one of my very favorite residents, Dr. Bharat Gopinath. We wanted to work on this crucial thing, which is the ST elevation myocardial infarction. This is a life-threatening acute coronary syndrome. Patients can very quickly die of arrhythmia and of cardiac arrest if not looked after properly. The American Heart Association has very clearly defined system goals of giving, providing door to angioplasty time or door to balloon time in this patient should be less than 90 minutes if the patient reaches the hospital within 12 hours. So if the patient reaches the hospital within 12 hours, the door to balloon time of less than 90 minutes saves lives. And that's what we worked on. That is what was a client. So we made a team. We looked at, this is an interesting thing we did. We made a stakeholder map. We looked at who was interested and who had the power to make a change. And we looked at, different stakeholders who are part of the team. And we drew this map. We actually published it also in the journal. We looked at the process flow chart. We looked at, again, meticulously looked at all the steps and all the bottlenecks. There was a delay in patient registration. There was a delay in performance of ECG. There was a delay in cardiology communication. And all of those things we addressed one by one. So obviously we looked at short on-site training sessions. We reduced staff turnover. We improved the communication with cardiology team by using a new SOP. We used a new SOP. We engaged with the cardiology team. We performed ECG quickly by asking the HA who was taking the patient directly to talk to the ECG technician and get the ECG before the doctor comes to see the patient. So every chest pain patient would get an ECG very soon. We wanted to, improve on that, but then we kept it very simple because otherwise it was getting difficult for untrained nursing staff to identify cardiac sounding chest pain patients. So we didn't want to miss any patient. So we just kept it simple. Any chest pain patient, send them inside, get the ECG done. And the HA would then quickly go to the ECG technician, get the ECG done even before the doctor was allotted to the patients. So simple things like that, we reduced the door to ECG time. And this was a run chart from this project. We did a baseline study for 2 months where the median door to balloon time was about 122 minutes. After interventions like formal training, posting ED senior residents, and common meeting fast track policy. We managed to reduce the time in about mid-August to 81 minutes, 81.7 minutes as the new median. So we reduced it to less than 90 minutes, which was our goal. Also, we made a slight modification to the process flowchart where I already discussed, we fast track patients and we interchange. So we were lucky enough to get this published as well in BMJ Open Quality, and where we highlighted all the key improvements which we made. This was another project which we did, advancing emergency airway management. We wanted to reduce the time from administration of paralytic agent until the placement of the ET tube. So we wanted to reduce that time, and we looked at that, and that was another project which we did. Right now we are we've just embarked into another project which one of my thesis candidates is doing again, and that is improving first pass success rate in the emergency airway management. That is to improve the intubation, first pass intubation rate in the emergency department. We just did a baseline study. It is only 68% right now. We are doing training, teaching, policy, improving and developing difficult airway protocols in order to make that shift and improving first pass success rate to, want to take it to more than 90%. So what were the key lessons? The key lessons were find solvable problems. So, I mean, we initially got carried away by trying to do very difficult projects. I've not shared those ones. I mean, there was a project we tried to reduce the transfusion time for some patient. That was really, really tough. We couldn't complete it, and we had to change the project, stop it in midway. The team leader, the team, as Dr. Deorari mentioned, team has to be very motivated, excited about changes. So take people who are interested, take motivated people, give them the roles, ask them to take leadership. Senior person, if involved, will really help the project. Focus should be on process improvement. And what we really achieved, I think we did, right now I'm working on my third MD thesis, MD in emergency medicine as a quality improvement as a thesis. So this is my third project. I've already done two. Both of them were presented in international conferences. Both of them got published in good journals. And so one of the key lessons and a message I'd like to share was, do it as thesis work. If you do it as thesis work, it gets done because the resident will take leadership, and you form a team, you work with the resident, and things were done. And quality improvement not just helped in those door time to door to antibiotic time, door to first medical contact time. That was not the only agenda. The agenda was to build protocols around it. So what we did was, through the project, like we never had a sepsis identification tool. We developed a sepsis identification tool because we did this QI project. We developed a fast track STEMI protocol because we were doing a QI project. We developed training schedules. We developed regular training programs for first line staff. We changed a culture. We developed a culture for continuous improvement, a teamwork. And I think it has brought in a lot of behavioral change, attitudinal change among staff. So I think it's just happened that way, and we've been lucky to have guidance by a lot of our guidance was from Department of Pediatrics at the All India Institute, where Dr. Deorari was heading, and we got a lot of inspiration from all the QI work being done in Obs and Gynae by Dr. Aparna, Dr. Parijat, who was doing a great work in ophthalmology. So we were only learning from them and somehow managed to pull through some good work. So thank you very much for giving me the platform to share some work, and very happy to answer any question. Thank you, Dr. Praveen. Thank you.
Thank you, Akshay. I think that was really wonderful. And my congratulations to you and Dr. Praveen Agarwal and rest of your team for really, taking QI in the emergency, because emergency is the area which needs most of QI, but often it's difficult to do because of the kind of trolleys you saw, the number of patients are more. And then on top of that, the flow of patients in emergency is really unpredictable. You don't know when the sudden crowd of people will come. Of course, you can have some patterns, But generally speaking, you can't predict. So how to deploy your resources, what time, it's very, very difficult. And everybody is, expecting instant attention, instant care. So I think I learned many things from your presentation. The first clear message was that whenever you embark on a QI, you have to define key performance indicators, which are relevant to patient outcomes. And as you saw in emergency, time is the most critical thing. Whether it's door to, first medical attention or door to first antibiotic dose. And to tackle these time problems, as Dr. Akshay rightly showed, they utilize this flow charting, process flow charting or the time flow charting, that what happens one after the other, how much time it's taking. And that often is diagnostic. It will reveal you some kind of less important steps which can be deferred later on, as they showed by kind of, deferring the registration process to later on. Or sometimes you will find redundant steps which are not really required. So I think it's a diagnostic and gives you a lot of change ideas. But I also heard from Akshay, they found duplication of documentation, which they eliminated. And I think this is a common scenario in all hospitals, all wards. Poor nurses are filling up register after register and same information. And nobody even looks at those registers later on. So I think we need to look around and see how much time is being wasted in unnecessary activities and try to streamline those and focus on what is really required. And I also like the thing that the hospital attendant was the one who gave the idea of, let's have this kind of red corridor. And the team readily lapped on it and made sure it was implemented. So you can imagine, the joy in the mind or the heart of the hospital attendant, who otherwise poor people, they are working hard, but nobody even looks at them. So I think it's a great opportunity, great learning from you, Akshay. And you also mentioned that initially you took up something difficult, which was not doable. And I think it's again an important message that if the problem is too complex, try to break down into sub-problems and tackle one thing at a time. You cannot do everything overnight. So be patient, take people along, take small things. And I think as he rightly and beautifully showed, all team members have to be co-authors, or they have to be recognized, and wherever you present, they have to be acknowledged. And I think especially the nurses or other people, if they see their name, it's not going to help them in their career at all. But everybody likes, they are being acknowledged, they're being recognized. So I think a lot of beautiful lessons, Akshay. Thank you. And I have just one question so far for you. It's a general question, although you highlighted, maybe you can briefly mention, how do we improve the outcomes? It's not a specific question, but maybe you can answer that.
Thank you, sir, for the question. So important is to look at, the outcome. What we looked at was, we were basically, our outcome was a process measure. So if you improve the processes, most of the time you will improve the outcome. Sometimes we don't have the outcome data. We didn't have the outcome data. Sometimes we don't know actually whether that, fast tracking that patient really saved that life or not. But it is, idea is to have an idea of the outcome. So the real good project would be where you can have an outcome study as well, analysis as well. And then you look at the processes, improve the processes, and then measure the outcome. So yeah, that's a very good question.
Yeah, I agree with you. It's something like, trying to improve hand hygiene. Now it's well proven, improving hand hygiene is going to decrease sepsis. So it's not essential that you must document sepsis came down when you improved hand hygiene, because there are other variables which will affect the outcome of sepsis. So it's quite okay to try to improve certain processes as outcomes, which are well known and well proven to be associated with better clinical outcomes. I don't see any other questions as of now, but later on, if they come, we will come back to you, Akshay. So thank you once again. And with this, we will move on to the next speaker, Dr. Parijat Chandra. So Dr. Parijat Chandra has been is from the Eye Center at AIIMS. And Parijat, if you can show your CV slide, I can just mention that. Yeah, so Dr. Parijat is Professor of Ophthalmology at RP Center. And his key areas have been retinopathy of prematurity, pediatric vitreoretinal diseases. He is a member of the National ROP Task Force, and he has been mentoring QI teams and also the chapter leader of AIIMS IHI chapter. I remember his collaboration with us as part of the Madhya Pradesh project, which was primarily to improve or decrease the ROP incidence. And Dr. Parijat was always there trying to interact with the ophthalmologists and trying to improve their, the way they work and the outcomes. So over to you, Parijat, with a request if you can stick to the time so that
Yes.
we can complete all the presentation. Thank you so much.
So I'll be talking about some success stories which we had at RP Center and some initiatives which we did, which you might find useful in your practice. So this is just a glimpse of some of the earlier days where we used to hold these QI meetings under the leadership of Professor Deorari. You can see him sitting in the center. This is me here, and a lot of the speakers that you see today are also here. Aparna is here. So this is the early days where we used to, do these meetings. Dr. Seema, Dr. Anu, Meena Joshi, a lot of these people were there. So they used to get together and do these meetings. And gradually, as we continue to learn and we attend a lot of these workshops and trained a lot of faculty members, a lot of residents, a lot of nurses, this group continued to grow bigger and bigger and bigger. And you can see a lot of trainers which came from the IHI. In the lower photos, you can see the director AIIMS standing there. So as Akshay pointed out, the leadership has to come on board. Once the leadership comes on board, they realize the importance of quality improvement, then it continues to grow and it becomes imbibed in the culture of the institution. So I'll talk about a few projects which we did. The first project which we did was a pilot project. It was a very short project which we did as a part of a 2-3 week study period. And the aim was to reduce the waiting time in the general anesthesia waiting area by 50% in 4 weeks in a single IOT. So you see, this is a smart aim where we have clearly defined what we want to do, how much we want to do it, and in how much period we want to complete it. And you see, it's a very small area. It's a single eye operation theater. So it's a very small project. And that's how you do a very small project, and you continue to make it bigger as you gain experience. So the most important thing before you do any quality improvement project is to collect the baseline data. You should know that a problem actually exists there. Then you can build on it and try to improve on it. So 8 babies came into that operation theater, and all of them, you see, were called before 8:30 a.m. 6 of them were called before 8 a.m. Typically, the OT will start at around 9 a.m. when the first case will start. So, all of them were there for the whole day, but outside the operation theater. 2 patients were cancelled after 5 hours of waiting. 5-minute procedure of an infected case was done after 6.5 hours of waiting of that baby. So you see, there was a huge waiting time which was happening in that operation theater. This is just a one-day data. And just, it was, mind-blowing that there was so much waiting happening in that OT. No one really managed to look into it, that so much problem was happening in that particular area. So the average waiting time was around 3.5 hours. Maximum waiting time was 6.5 hours. So we tried to, see why it was happening. So in the words of the great Dr. Deming, who's also the father of quality improvement, if you can't describe what you are doing as a process, you really don't know what you're doing. So Dr. Ashok showed you a lot of these flow charts. So that's how you have to put these things into perspective to understand what your process is and how you can improve it. So this is what our flow process was. So if I go from the left side, the junior resident calls all the ward patients. Then the JR calls for the NICU bed to arrange if there's a post-operative support for these babies. Then the baby with the parent leaves the ward. Then he comes at the OT reception area, waits in the general anesthesia waiting area. If the surgery happens, then he goes and shifts for surgery. If surgery doesn't happen, then he waits for confirmation and he goes back to the ward. So, so this is the general baseline flow process which was happening. So as Dr. Deorari suggested, we go through various PDSA processes. So the green boxes now highlight what we changed in the system. And then I'll come to you what the change time was. So this is what we changed in the system in the first QI meeting which we did. So we said, okay, there's a lot of waiting time. Don't call all the babies in the morning. So if you see on the left side, call only the first 2 patients. Don't call the rest of the babies in the morning. Don't call anyone before 8 a.m. because anyway the OT is closed before 8 a.m. No use calling all of them. And only a single resident calls, because what happens, multiple residents were calling these babies. And then, the sister used to get confused in the ward because multiple people were calling and she used to send all of them. On the right side, if you see what is happening, the resident escorts the patient out from the OT. So if there's a clear message, the surgery is not happening, you don't let the patient keep on waiting. Again, the patient is confused, he needs to go out or doesn't need to go out. Maybe he will go out by mistake. So the resident escorts the patient out, tells him your surgery is cancelled and he takes the patient home. So there's no waiting time for the patient pending a cancer procedure. On the top right, what you see is he calls the third case only when the first case exits from the operation theater. So the third case does not necessarily have to wait in this process. So this is the part, phase one of this process we did, and I'll show you later how this reduced the time. Then the time did reduce a little, but did not reduce significantly. So then what we did is further tweak the process over the next OT day. And then we said only call one patient. Don't call all the three, only call one patient. And the second patient will only be called when the surgery of this patient starts. Sometimes what happens during anesthesia, a lot of time is wasted for the patient, to go into GA and get intubated, and then for the procedure to start. Or maybe the patient has a bilateral procedure. So why should a patient wait when the procedure is going to take, let's say, 3 hours? He doesn't need to wait. So if you see the top right, he will call the second patient only when the second eye surgery starts. If it's a bilateral procedure, or if it's a unilateral procedure, then only when the first eye surgery starts. Other small things which you can see were done in the middle, that, the patient already is prepared in OT clothes, and, he checks in repeatedly at the reception because there are not a lot of patients waiting. So let's see what happened after this. So the average GA waiting area time reduced dramatically. So it was initially, if you see on the left side, it was 221 minutes. Then we ran the QI phase 1, which is on the first chart, and QI phase 2, which is on the second chart. And now what happened is, over the next 4 days, the time was sustained. So if you see this pilot project, there are only 6 operation theater days. It's not a very extensive project. It's not like over weeks and months you need to run this to do this. It basically ran over 2 days. And the rest all days are all sustaining collection data, right? So you had 2 days of baseline data and quick PDSA changes, which we did on these 2 days. And we brought it down by 87%. From 221 minutes, the average count came down to less than half an hour. And this was all possible because of 1, baseline data collection, 2, rapidly doing changes, which we thought were very obvious, and bringing it down. And the best part is only 1 junior resident was doing this whole coordination thing. You didn't need multiple people to do this. And let's see what happened to the maximum waiting time. So I showed you the first child waited in the baseline data 390 minutes, 6.5 hours he had to wait. And while we quickly implemented this over 2 days, 2 operation theater days, you see it came down to less than 1 hour. Right side data, which we're trying to show for the next 4 days, is we are trying to show that the waiting reduction sustained. So in any QI project, you have to see that the changes which you rapidly brought out, are they sustaining? Maybe just a 1 day blip which happened, it worked out for 1 day, and another day it didn't work out. So you have to check for sustenance of data. Now, you see, this is just a 6 OT day project. Again, I'm trying to say the same thing. You don't have to look for something very elaborate. It's happening in front of you in your own areas, and you don't have to wait for any administrative person to come and look into these areas. It's your area, you know these areas best. Just go ahead and see what is happening, and you yourself with the QI team will be able to understand what changes you can rapidly do to bring it about. And see, the same single resident, was able to independently do all these changes. The second project was a more bigger project. We once we gained experience doing these projects, we realized, we could work on a bigger scale. So here the idea was to reduce the waiting time of preterm babies in ROP clinic by 30% in 8 weeks at RP centers. This is just a quick glimpse of our waiting area for ROP clinic. So here again, we mapped out the baseline process. So the process is the patient reports to the clinic. This is probably works for all your clinics which you do in your areas. It could be any department. So it's typically how it looks like, Patient reports to the ROP clinic, counter registration, dilate the pupils. JR comes at 2 p.m., sorts all these cards. SR comes at 2 p.m. Second SR, if he's available, he comes or does not come. Faculty will come at 2:30 p.m. So this is typically what happens in all clinics, whichever area you're working, and they all see all these clinics and the patient exits out. This is typically how our clinics look like. And, 3 counters are there. People are seeing these babies quickly. And when we measured the baseline data, it was 90.5 minutes average waiting time. Maximum waiting time was 3 hours. You see, these are fasting preterm babies, and they are waiting for 3 hours typically when we collected this data. And the last baby entry time, which is the last baby which enters the clinic, is 111 minutes median. So there's a huge waiting time happen here, and this will only you will be able to. So we were working in this area for a very long time. We never realized that the babies were waiting for such a long time. So unless you collect the data, measure the baseline data, you will never know that a problem exists. So again, we did multiple rapid PDSAs here. We said that the JR comes at 2 p.m. Don't do a random sorting, sorted them out in the reporting order. And the second SR, we said you come at 2 p.m. So it was not a random, he comes or does not come, depending on availability. We increased the capacity of the clinic and bought another counter where he could be able to see this. In the third PDSA, we said, oh, why should the faculty come at 2:30? Because the babies are waiting. He should also come at 2 p.m. So all the staff, all the 3 counters start at 2 p.m. And if we are really waiting, why should we not push it a little further? So we said you come at 1:50 p.m. When babies are waiting for long, why do you want to start everything at 2 p.m.? You come at 1:50 p.m., sort the card before that. And the faculty, why does he need to wait for, why do all the people need to wait for dilated babies? Faculty can see post-op babies where the baby is not dilated. So you don't need to really come late. You can come in time and see the new cases as they're being worked up. And you can see the cases which are not dilated earlier, right? So this is what happened to the average waiting time. So you can see it decreased by 18% from 1.5 hours to 1.2. So this is not much. This is not much. So this is just to show you across 19 clinic days. So this is what it happens. So we have a clinic twice a week. So this is across a period of a few months. And you see the average waiting time did not reduce. But what reduced was the maximum waiting time, which you can see reduced by 31% from 3 hours to 2 hours. So it's a very busy clinic where a lot of babies are coming and reduced by from 3 hours to 2 hours. And the last baby entry time reduced from 2 hours to 1 hour. So you see, this is moving very fast now. And if you don't measure it, you really don't know what reduced. And you can see that the data tended to sustain, and you can then calculate the median, and this is how you can document it. So the parents were very happy for a lot of reasons. Why? Because there was less waiting. So that is what the aim of the project was. There was an orderly flow because the staff was coming on time. People were not unnecessarily waiting. And they were very happy to see that the staff is coming on time and the clinic is starting on time. And the staff was happy because the clinic finished early and they could grab a cup of coffee. So you see how, rapid PDSs led to continuous quality improvement. The important thing here was that all these papers were published, and it gives a lot of ownership to the team that these projects were published. This was, again, as Dr. Deorari pointed out, especially from Indian pediatrics, which was brought out for quality improvement. A lot of teams from India in different hospitals participated and presented their QI projects. A huge movement was running across India in those years because all these teams were learning. They published all these papers. And just a quick glimpse of the people, the students, the residents who participated in these projects and who led these projects. They went out and presented these posters in the BMJ international exhibitions and the conferences, where they had an opportunity to present their work and take ownership of the work and get a good CV as well for this work. The third project which I want to present, these quick projects. So this was now nursing led. So not only the doctors and the faculty and the residents were getting involved in this, the nurses were also getting very inspired by this. They were getting inspired by the quickness and the rapidness which we could do these projects. They were inspired by how it brought about change without any extra cost, without any administration involvement, and how they could do it themselves in their own areas. So the nurses in the operation theater, where we were doing this, they saw, that the surgical time was not optimum. The resident and nurses were not scrubbing properly. They looked at this bottle, you see how simple it is. They looked at this bottle, which says that you have to wash for 2 minutes, right? And they said, okay, the doctors and nursing are, rapidly washing and then just running to the OT areas. So this is not the right time. So they said, okay, we are going to do a project of improving the scrubbing time to 2 minutes in the GA scrub room of a single IoT in 1 month. Right. So you see, it's so simple. So this was a nursing-led project. So they did a quick baseline data collection. You see, just 3-4 OTs, and they said, baseline data was 1.4 minutes only. This was not what was recommended in the bottle, which was 2 minutes. So then what did they do? So they went ahead. You see this nurse, which is there on top. She's quietly standing outside the scrub area in our IO operation theater. And she is just trying to see how much time each person is taking, quietly noting it on a piece of paper. Then, she sensitized it to the various teams of nurses and resident doctors, which you see standing there. You see, this says you have to do it for 2 minutes. It's very simple. There's no protocols. There is no elaborate literature which she's showing. She's just showing them. See, the bottle says you wash for 2 minutes. So you please wash for 2 minutes. The baseline data which you collected is very less, which is not optimum for the surgical scrubbing time. And it compromises with the patient infection control in the OT. So please do that. On the right side, what you see is she put up these notices. Kindly scrub for at least 2 minutes. Simple measures, just 2 measures. You see, there's not much detail in this. Just 2 simple measures, sensitizing the team, putting a notice. And let's see what happens. So you see PDSA1, they sensitized the teams. Nothing much happened over the next few days. 2 days they measured it. So they said, oh, we have to push it further. Second measure which they did was put a reminder poster in the scrub room. And see, the target of 2 minutes was met. And the new normal was 2.5 minutes. So they did actually more than what was expected. And then, you have to measure the sustenance data. So that is, I think, the most important thing which you do. You get the baseline, you see the sustenance, and you see it's sustained. The next project which these nurses did, again, it was a bigger project. Again, they, got a lot of confidence with this. This was a much bigger project. And now they decided to improve the completion of e-learning modules of infection control by 60% for nurses in 3 months. So this was a e-learning software which the AIIMS administration included for nursing programs, where they said all the nurses in the hospital should undergo this program of infection control. It was an online module which nurses had to do, part 1 and part 2. So when they started doing it for 8 weeks, none of the nurses were interested in doing this. So this was a data collected for around 300 nurses in the entire RP center, which is RI hospital. And 8 weeks, the baseline compliance was very poor. None of the nurses were doing it. So then they called in the QI team. They were very inspired. How does the QI team get this thing done? So the team came in, just 3-4 nursing leaders came in. They decided, okay, let's do it. Let's see how we can, if we can do something about it. So they started putting in place and started doing it. They identified a lot of problems. So there's a server problem. So they emailed the IT teams, sometimes the computer is working, sometimes the software is working, not working. They said, some of the nurses were not so computer literate. They said, they called in informatics team. They said, train them how to do it. There were time issues. There were no approved, protected time where they could do it. So they were just not doing it. So they created protected time. There was a computer availability issue. Sometimes the doctors and residents were busy, typing things, making discharge cards. So where is the computer to do it? Even if you have protected time. So they identified a store computer in the ward where they could do it, which was lying idle. They created motivation, interest. An official memo came from the administration. You have to do it. It's mandatory. A lot of communication gaps were there. So they fixed all this up. And this is just an idea of how the training schedule they created. They created protected time for different nurses in the ward areas. So, like the sister names which you see, when will they be allowed to do this, leave their ward work and actually do this thing? So that's how they created it. And you see, this is what happened. So you see on the left side, 8 weeks data was the baseline data. Then the QI started, and gradually over the next 5-6 months, you can see the nurses started getting trained. And at 24 weeks, 98% of the nurses were able to do part 1 and 96 nurses were able to complete part 2. So this is the power of quality improvement, where you can just identify some basic measures and, work on them, work with the teams, and any project, any area in the hospital, you will be able to achieve what is, needed if you work with these quality improvement methodology teams. So again, these were, as I told you, both of these were nursing-led projects. Both of these projects were, published by the nursing leaders. They got together. You see, these are all names of nurses which you see here, and they worked together and published these projects. Very important, to publish the projects. One, it validates that your project was done with the proper methodology. It validates through a peer-reviewed process that what you did was actually, is worth reading by a lot of people, and other people get an inspiration from this. And obviously, it's in the public domain now. So, you can, give out these projects, PDFs to your colleagues, your departments. You can inspire other people to go ahead and, do the projects like this. And they also themselves can, do these and get inspired when they see the success stories coming from different teams. And this is what is happening now, So nurses are leading the QI in RP center in RI hospital. And there's a massive movement going on. This is Sister Dolma, which you see on the left side. She's a nursing educator, nursing leader, which did the projects which I showed you earlier. And this is what you see on the right side. The top right photo is again the earlier days where Professor Deorari is giving us a lecture. And what you see on the right side is the nursing superintendent. And these right 3-4 sisters which you see are deputy nursing superintendents. So when you see the leadership gets involved, it's not about just 3, 4, 5, 6 nurses. The photo on the right which you see are nursing superintendent leading meetings and doing QI meetings to see what the nursing leaders are doing and what nursing projects they're doing. So in conclusion, I would just like to say that quality improvement is a common sense approach. You don't need to do a lot of research or do a lot of public PubMed search and to gather huge teams and work. It's a common sense approach. You have to just see what is happening in your area and figure out what is the problem, collect baseline data, and through common sense approach, see how you can do it. You don't need to do anything big. Simple changes. Usually what we showed you were very, very simple changes. Education, putting posters, tweaking small processes, and it can make a huge difference. But the important thing is to measure it. If you don't measure it, you can say I did a very great job. But if you don't measure it, you cannot tell people, something great happened. So as Dr. Deming says, we only believe in God. The rest all, you bring data, right? So you have to bring data. Without data collection, you cannot say the baseline is bad. Without data, you cannot say it improved. And obviously, identify motivated team members, people who really want to get working on this, who get excited by this, join hands with them, and then you can improve healthcare systems very easily. So quality improvement ensures better patient quality of care, and you see at no extra cost. Thank you so much.
Dr. Parijat, and hearty congratulations once again to you and your team and your group of nurses for really taking up multiple projects. And what I notice is, all the projects have outcomes which are patient-centric, trying to reduce waiting times, trying to decrease infections due to hospital, acquired infections. And I'm very glad you looked at waiting time in the operation theater, because if any one of us really walks to the outside the operation theater complex where the attendants are waiting, or in the pre-op room where the patients are waiting, you can look at the mood in the beginning at 7 a.m., 7:30 a.m. Walk again after 2-3 hours and 4 hours, you can see how the mood is changing. In the morning, people are excited, very hopeful. My surgery is going to be done, family is happy. And then, but there's so much uncertainty because everybody has been called together, as you rightly said. So they are waiting, and by lunchtime, there's a lot of kind of resentment, disappointment. They see some patients have been operated, my turn is still not coming. And then, as you said, some cases get cancelled. So it is so frustrating. They're staying nil per oral for the whole day, and then going back to the room that today's surgery is cancelled, and next day, I don't know when it will be. So I think all surgeons and anesthetists, I think, should walk incognito in these pre-op rooms and see how patients are talking to each other, what they are thinking and talking about. And then I think they will realize how important work you have done, and same example can be followed by other people. I think a couple of very important points which you made, that unless you measure, you cannot really be sure you are improving or not improving. And hence, baseline measurement and repeated measurements after your interventions, using a standard operational definition. It's also important that the measurement should be with the same scale, same kind of tool. It should not happen that measurement itself is changing, so that you're confident, yes, things have actually improved. And again, a very important point Dr. Parijat made, that it has to be sustainable. It should not happen that the QI project is over, everybody forgets, and after a few months, like a rubber band, it goes back to its own original position. So which means you have to incorporate some basic measurement stuff into your routine practice, so that there's somebody looking at, okay, are we performing similarly as we were during the QI project? Or things are maybe turning back towards, worse again. So there has to be a, track keeping, and some simple 1 or 2 measurements can be made part of the system. And one recurring theme which came from Dr. Akshay and Dr. Parijat also again was involvement of nurses, doing multiple projects, recognizing the nurses and the frontline residents, so that your culture actually changes. And culture doesn't change overnight. It takes, I think, years. And this is what both these people have demonstrated, that they've been able to change the culture so much that nurses on their own are now, doing all this and leading this improvement. And one small important thing, again, he showed us the importance of visual reminders. Simple reminder, okay, scrub for 2 minutes. Or in case of Dr. Akshay, using color-coded wristbands. So visual is always better than, audio. So try to use visual cues, visual kind of intervention, which can help. So wonderful, Dr. Parijat. Once again, I congratulate you for the great work.
Praveen,
yes, Dr. Deorari.
Hey, Aparna has a flight to catch. She's sitting at the door for catching her flight at the airport.
Okay.
Can we have her presentation first?
Okay, so we will, Sindhu will request you to do it after Aparna. So Dr. Aparna, can you show your first CV slide? So Dr. Aparna is again a champion QI expert from the obstetric side. And if you can show your slide, first slide. Yeah, thank you so much. So Aparna is again additional professor in the Division of Maternal Fetal Medicine, Secretary of Society of Fetal Medicine, North Zone Coordinator for Safe Motherhood Committee, and chairperson for AOGD Quality Committee, and won several awards and fellowships. And I think, again, she is one who is so passionate, so full of energy and enthusiasm. So over to you, Aparna, for sharing your experience with us.
Thank you, sir. Thank you very much. And I'm really thankful to Dr. Deorari, sir, and the whole team for having me here today. And also, thank you, sir, for adjusting me here. And thank you, Dr. Sindhu, for letting me speak first, sitting at the airport. So I would say that, quality improvement is a way of life. I'm really thankful to Dr. Deorari, sir. From 2015 onwards, we have been introduced to next sir, I just got into quality improvement, and from then I saw quality improvement. What I'm going to talk about today, and what Dr. Parijat and Dr. Akshay has been talking about, is actually the success stories are just the tip of the iceberg, because so many other stories are there that we are actually not talking about. So how I am going to talk about is how we've actually, somewhere incorporated quality improvement in various areas of our work, and talking backwards from our published stories on where, quality improvement has really shown effect. So this was one of our recent publications where we talked about the practice of birth companion in the labor ward in our own institute. Now, birth companion in labor is something which was unheard of some years back. And when we talk about birth companion in a government hospital, that was something that we thought that can never really happen. And when we started thinking about it, people said, how can you have a birth companion in a labor room in a government hospital? So we started by making an SOP. That was the first PDSA. And then we had, sensitization of people, sensitization of the staff, and sensitization of the sanitation staff. And then we had different dress code, which was identified for a birth companion. We made posters. And then we had senior faculty on board, coming in board, who said that, okay, it is possible to do birth companion. And slowly, but definitely, we did have a gradual improvement when we started having birth companion. And I must say that it was not just AIIMS, but from AIIMS, we actually did a thesis in birth companion, even in AIIMS Rishikesh, where one of our faculty actually went over, and now we've done a thesis in birth companion, even in AIIMS Rishikesh. Following this, we have another project which we did in the COVID pandemic. Now, quality improvement in COVID pandemic is something that, people will think about. During the COVID pandemic, can quality improvement principles actually work? So what happened in COVID pandemic? We all know that the wards in COVID pandemic became like black holes. Like, somebody who went inside the wards, there was absolutely no communication. But when you talk about pregnant women in COVID wards, it was so difficult to, really, and patients would not get admitted just for the fear of no communication at all. And that is when we decided to start a QI project on establishing communication with the relatives of the obstetrical patients who were admitted with COVID infection, because essentially these were healthy women, more or less, and they were just COVID positive. So we had various methods. We decided why we were not communicating. And this is that fishbone analysis that we did, that there was a problem with people. There was lack of awareness. There was no place to communicate. There was no time assigned. There was no policy and there was no procedure. And based on all of this, we devised a method where we would ask the duty team to actually communicate with the duty mobile, that they would use the same mobile to call up the relatives of the patient and make them talk. The doctor itself would talk and talk to the relatives of the patient that this is the situation of the patient, your patient is all right at the same time. So that the patient, the relative and the doctor are on the same table and they understand what is happening. So this proper clinical debriefing session of the COVID positive patient and the relative was so satisfying for the patients during the COVID pandemic and had a huge impact on the admission rate and patient satisfaction rate during the COVID pandemic. So our daily clinical briefing, and this was sustained throughout the COVID pandemic. Another important project that we did was in the rural setting. So this was actually done interestingly by one of the interns who was really troubled by, so this particular thing was guided, mentored by me and Dr. Anu together, who was, introduced, and he was very, very excited by the quality improvement methodology. So he did actually a prioritization matrix where he saw that there were multiple problems plaguing that place. So he did a prioritization matrix, delayed cord clamping, vitamin K administration, neonatal hypothermia. And he also thought that the first information sheet of a patient pregnant woman who comes to the emergency is not complete. So the interns are the primary caregivers in a rural setting of Ballabgarh of AIIMS. And he was worried that the information that is being filled at that particular point is not complete. So he decided to take up this project and work it up completely and do this project in the emergency of a rural setting of AIIMS. So by various PDSA cycles, he decided that, okay, he can actually implement this by definite processes, by orientation of the various teams that come in, that it is possible to actually implement it and sustain it over a period of 6 months to 1 year, even to the next batch. So all of these publications have been done in BMJ, and it was seen that it was a sustainable change which was seen. Now coming to the departmental quality improvement projects that we have done over a period of time. Now, one of the earliest and the most interesting projects that we have done was reducing waiting time to initiation of infertility treatment. Now, how this came about was one of our very interesting initiatives that Dr. Deorari started was the resident orientation for quality improvement. I think his idea, like this particular project, is that the budding residents should be ingrained with the idea of quality improvement. In the very first orientation session, one of the DM students came up to me and said, ma'am, do you even know how many visits does a basic infertility patient take to actually start a treatment? And she made this flowchart that it takes at least 6 months for a patient to even start thinking of a treatment, where the first visit had history, the second visit has a blood test, third visit has an endometrial biopsy, fourth visit she collects report, the fifth visit has an HSG, the sixth visit has an HSG report, and then finally she gets her treatment done. Now this is called a process flow map, and she made the process flow map like this. Following all of this, we all sat together, including the senior professor of the infertility department, and we said, what is happening? Why can't we minimize some of the excess steps? And this is one of the earliest of our publications, and with concerted effort from the radiology department, who said that we can actually give you extra slots for HSG. Nobody asked us before, because nobody realized that there was so much of waiting time and nobody was working on it. So we actually got extra slots for HSG, and we clubbed some of the processes together, and we managed to decrease the waiting time to start of infertility treatment by this quality improvement measures. And this was one of the earliest publications. Now, this is one of our recent ones where we realized that AIIMS is one of the most, a department where we have most high-risk pregnancies. So a lady will have diabetes, hypertension, ICP, and any medical disorder, you name it, and we have it. So we did not have a standard protocol for a standardized workup sheet. So this was one of the other initiatives that we had recently started, and which was actually sustained over 4 years before publication of this paper. So this was kind of a completely sustained QI project, and this finally got published only this year. So this was one of the longest sustained projects. Then this is a thesis that was very recently concluded, and a very satisfying thesis, because of this initiative, a new practice of birth planning, which is a revolutionary practice in the sense that we have been advocating this practice that every woman who's pregnant should have a birth plan counseling at 32 weeks. And with this thesis, we have been able to establish birth planning for all women in our antenatal clinics. So this was a thesis which was done, a quality improvement thesis, to establish the practice of birth planning from 0 to 50%. In the process of a thesis, before that we established the baseline, we created forms, we created a questionnaire. So it was entirely thesis which was actually sustainable, because we shifted the onus of birth planning during the process of thesis from the JR to the family planning staff. And that is how we established sustainability, that even if that JR has now finished her thesis, during the process itself, with the help of our head of the department, we transferred this process of birth planning from the JR to the family planning staff, which has now become a process of care. So this is how the PDSA cycle went, and now this has become a process of care within our normal antenatal care of birth planning. Now, another very interesting aspect of quality improvement is how we have integrated quality improvement in family planning. And now this has been actually been projected to the other hospitals of Delhi, and they are planning to take it up of quality improvement in family planning. We presented this very recently in a RCOG conference, where the postnatal clinics were actually finished completely in the COVID pandemic. So we restarted the establishment of postnatal clinics by starting from simple measures, by putting a stamp at discharge on the discharge slip that you have to come back at 6 weeks. The idea of PNC clinics was actually dying completely, but with the help of our head of the department, and then we started calling people at 6 weeks. So something that we have done and sustained now, that our PNC clinic attendance has now increased to almost 60% with the help of this simple quality improvement methodology. And similarly, the acceptance of postpartum contraception again has improved from something like 20% to 80%, and has been a pillar of improvement through these methodologies. So postpartum contraception is something that is also a very, very important and greatly and hugely appreciated now by the Delhi government itself. And we've used quality improvement methodologies on what are the basic problems with postpartum contraceptive acceptance. So for this, we have actually introduced new methodologies. Can new methodologies be used? Why the women are not accepting? What are the better counseling techniques that we can use? So using these analysis methods, we have done this. Now, how we have incorporated quality improvement in state. So now, in terms of obstetrics, QI has become a movement. Like, we have actually started a quality improvement committee as a part of the AOGD. AOGD is Association of Obstetrics and Gynecologists of Delhi. And now we are teaching QI methodology in Hindi to ASHA workers. So we did a small workshops with more than 100 ASHA workers of Delhi to talk about anemia mukt Delhi. So we tell them simple steps of data collection, simple PDSA cycles to understand why women are not taking iron. And if they are not simply taking iron, the next step is IV iron. So with this, we have actually been working with 4 districts of Delhi, more than 100 ASHA workers. And this is one of the most interesting works of quality improvement that we are currently involved with. And we'll see how things are progressing now in the coming future. Now, in terms of quality improvement in the country, Lakshya is something that has to be, it's a labor room quality improvement initiative by the government of India. And we have been involved with Lakshya since 2018. And QI is an integral part of Lakshya in terms of process improvement. So there are a lot of mandate within Lakshya which has to be achieved. Like, for example, birth attendance has to be there, safe surgery checklist has to be used, partograph should be used, and breastfeeding should be started within 1 hour. So as a part of GOI mentoring program, we had made a team of coaches, quality improvement coaches, and we took around on-site. So we took around 12 medical colleges in the country. So small group of mentors and coaches, and we took 12 medical colleges in the country. So in the first step, the small group of mentor colleges were allotted medical colleges. In the second step, we went on site to mentor those for the methods of quality improvement. In the step 3, the processes, they did a lot of quality improvement projects. And in the step 4, we had online meetings with them to help them achieve their methodology. So these were the 12 medical colleges in which all of this online online quality improvement coaching was done. And these mentors were the pool of quality improvement mentors that we have been working with over the last 7 to 8 years. So some of the pictures of the on-site mentoring which have been done across country over these years. And a lot of potential rapid improvement cycles which can be done through quality improvement, like hand washing, birth companion, skin to skin, and real-time partograph plotting. So as all of the previous speakers have been telling us, as Sir has been telling this I think is one of the most powerful tools which has been handed over to us. And if we can use it on our day-to-day life in clinical practice, this can help improve a lot of things. Now, the second part of my talk would be resources for quality improvement. So I would say that as students, you have a lot of resources that you can learn quality improvement for, but I would request that it is always interesting to attend one POCI workshop physically, and then of course, you know, attend, go to the website. But till the time that we are not able to organize a POCI workshop physically, there is nothing like a POCI physical workshop experience. But we should definitely visit this website. Now, www.pocqi.org. It's a very enriching website. You have the entire POCI guide here, which has webinars, which will give you the entire substance of POCI. You have the learner's guide, you have the facilitator's guide, you have the PowerPoint with explanation. And when you want to do the project, you will get the project template also. So this is the coaching manual and the learner's guide. You have the PPT with the explanation, which will tell you how and what the meaning is. Then you have the project template, like what is your aim statement? What do you want? Why is this a good aim? Which is the team that you should choose? Then you report what you want to learn. The other learning resources are, you can see the posters, like the projects that we are presenting. There are projects that has been done. And also, there is no plagiarism in quality improvement. Please look at the posters. Please take us from improvement project, because it is always, you know, you have to personalize them for your own setting. That is your own project. That is what you've done for your own setting. So you need to look at, you can look at these projects, videos, webinars, and also case studies from various things. And as Sir was mentioning, the whole issue of Indian pediatrics is about projects. Get ideas, get inspired, and do it in your own setting. So that's very, very important. So some of the examples of the posters which are available. So this is the issue of the Indian pediatrics, which is available. And one of the most important thing that you can do is the 4 steps of care. And that's point of care quality improvement. It will give you step-by-step guide to quality improvement. So the step 1 is identifying problems, give you a case scenario where it will tell you, okay, this is the situation, what will you do next? And once you answer this, it will say, congratulations, you have completed step 1, step 2, step 3, step 4. And now once you have learned all the steps, it will give you a certificate of participation. And trust me, you will feel proud after you get this certificate, as I felt proud when I got this certificate for the first time. So believe me, you should go back and check out this website. This is one of the most useful websites you'll ever find to learn quality improvement. So you have lots of resource materials, PowerPoints, manuals, webinars, posters, and activity logs, and lots of opportunities. and videos and country reports. So get inspired and just do visit the website and do the virtual booking course to know more about quality improvement. And if you want any clarification from our side, most welcome to contact us. Thank you very much.
Thank you, Aparna, for that wonderful presentation and sharing your experience across several projects within the institute, within the state, across the country, and with various associations. I think a couple of important messages, but I can see, it is a good idea to align your improvement efforts with what the government is doing. So Akshay is one good example where government has already given you key performance indicators. And so it's very easy. All you have to do is measure at the baseline, apply the POCI methodology, and make contextual changes and try to achieve improvements. And very rightly, Dr. Aparna showed that even in the busy government hospital with limited space, a different kind of mindset, it was possible to achieve the presence of a birth companion and, similarly then trying to have a birth planning, which is sadly missing in most places. What I also liked from Dr. Aparna, and I think even Dr. Akshay and Parijat also highlighted, is, when you have a problem which involves different stakeholders, you need to speak to them. So if it's the problem of radiology, unless you go and talk to them, it will not improve. So we have to come out of our shell. If it's a problem of supplies, we need to go to the store person, storekeeper, and talk to them. And simply talking to them sometimes it's so simple, solve the problem so easily. As she said, they were not even aware that, this is the problem. What I also kind of noticed that, we keep cribbing, shortage of manpower, we need special person also. So now if you look around, there can be category of staff who are actually underutilized. So I think the family planning staff was a very good example. They've been there for years and years. And if you look at what they do currently, they are often sitting on table and having tea and coffee. So task shifting is something which is very useful within the same. And I think there are several examples of that. When we did our early initiation of breastfeeding project in PGI during cesarean delivery, we found that the anesthetist and the circulation nurse were kind of more free. They had some work to do, but then a lot of time they were simply there reading novel or something. So we involved them and they were very happy to, assist the mother, hold the baby on the baby's breast. And that way, and they were very excited, okay, we are doing something productive. Similarly, in Madhya Pradesh, we saw the security guard manning the SNCU was doing nothing except, guiding people and controlling the crowd. But then once that fellow was involved in promoting hand hygiene or breastfeeding, things improved and you did not need an extra lactation counselor or somebody to come and, train people. So look around, you will find people who are underworked and who will be excited to join your movement. So this is one very important, I think, learning I see. And another good thing is that trying to simplify QI in the local language. So if you're going to ASHA workers, obviously you have to talk in their language. So converting it to Hindi, training them in Hindi, I think is really a great step. And this will really help. And simple things they can also do. So I think wonderful once again, and I can see the cultural change in your department and in other states which you've been able to achieve through your association. So that's again wonderful. Thank you so much, Aparna. I can check if there are any questions right now.
Praveen, I just wanted to share a small story.
Yes, sir.
In 2016, we had a meeting of WHO in Sri Lanka. We were flying back from Colombo to Delhi, and Aparna was next to me in the aircraft. And she said, I am very passionate about fetal therapy and stuff. So I converted her in that flight that QI has to be taken forward by the obstetrics department. And then she taught me all the tricks. How do you convert the leaders and the head of the departments that QI has to be taken forward and gradually keep on increasing the network of QI faculty members and their. I think she, Parijat, and Akshay, all are even S.Sindhu and Deepak, they are very, very passionate about quality improvement. You can make out that from their presentation. So they have left us behind and moved fast forward, much ahead of what we knew about QI.
The marker of success of the movement, that more people take up, younger people take up, and they become the next leaders. So thank you, Aparna, in spite of your flight waiting for you, for taking this talk. Thank you so much. Next, we move on to the next talk by Dr. Sindhu. She is a neonatologist. Sindhu, can you share your CV slide? Yeah. So Dr. Sindhu currently is consultant neonatology in Cloud9 Hospital, Chennai, but previously she has been working in AIIMS Delhi and then has been consultant in JIPMER Pondicherry. And again, a master QI expert, a master teacher, and I think all students like her the way she teaches. And her recent QI works have involved family-centered care, functioning of human milk bank, etc. So over to you, Sindhu.
Thank you very much, sir, for this wonderful opportunity to share the QI work that we have been doing with newborn children. So the objectives of today's talk would be to learn how QI initiatives can be used to prevent a simple problem like hypothermia in the newborn, and how we can do a QI project in our own unit. So for this presentation, I would be taking one particular example and going through all the steps. So when we choose our first QI, it should be very simple, easy to do, and easy to measure. Here we have two QI projects, one trying to maintain the normal temperature in the newborn baby, and the other a very important and burning problem, which is prevention of bronchopulmonary dysplasia in preterm babies. Both are equally important problems, but which one do we choose when we first do our QI? So look at whether which intervention is easy to apply and easily available. Which one can you coordinate well with the multidisciplinary team? Which one can you easily measure? So the thermoregulation project satisfies all the criteria. So when you first start out, do the simple ones first. So we all knew when we were working at AIIMS, the best practices for maintaining normal temperature, especially in preterm babies. The neonatal resuscitation program tells us that when it comes to preterm baby, you need to use additional measures in addition to just the radiant warmer, like use plastic bags. Sometimes you might have to use the thermal mattress, and you need to have the transport incubator ready, because warm transport is also essential. We thought that we knew all these interventions and we were doing a very good job. But when we looked at the first 10 babies who were less than 32 weeks gestation, in whom we measured admission temperature, we were surprised to find that the admission temperature mean was only 35.6 as opposed to a normal temperature of 36.5. So then we thought, where are we doing wrong? We thought we knew everything. To correct this, we started out a quality improvement initiative. So when we plan our QI, we should have a SMART aim. SMART aim is a mnemonic to suggest these points, that the aim should be very specific. We should know what are we trying to improve. In this case, it is admission temperature among preterm babies who are less than 32 weeks gestation. Second, it should be measurable. What is this we are going to measure? Which is admission temperature. Here we have to specify who would measure, how would they measure, and when they would measure. So, for example, in this we said the admitting nurse would measure the temperature as soon as baby comes to NICU within the first 10 minutes of admission with the digital thermometer placed in the axilla. So it's very clear. Achievable. The project that we are trying to improve should be achievable within our limited limitations, and it should be realistic and time bound. There should be specific time within which we want to improve. So this is how we thought of the study plan. First, there would be a baseline period. The baseline period is basically to get the initial data, which may not always be available. And second, to see where are we lacking? What is the gap? How can we improve, right? And then we have the implementation period where we can try out the various change ideas. As we discussed earlier, at the end of each plan, do, study, act cycle, the change ideas can be absorbed or adopted for implementation, or they can be abandoned, or we can adapt it. So we can run a number of these rapid PDSA cycles until we reach our goal. And third is the post-intervention phase. This is to make sure that the project is sustainable without additional PDSA cycles. So we'll see how we did this. So in the baseline phase, we did not make any new interventions. We appointed a healthcare provider in the labor and delivery room or in the OT where the baby was born, just to observe what were the things which are being done. Are they applying the plastic cover? Is the transport incubator available? All these things. And we standardized the measurement of axillary temperature. Second, we formed a QI team. So here, because the babies are born in the labor and delivery as well as in the OT, we need to involve multiple stakeholders. So we involve nurses, the charge nurses, nurse educator, as well as staff from labor and delivery room. So then we reviewed the guidelines as well as the literature, and we thought that we will implement this thermoregulation bundle, which means that all the aspects in this bundle need to be implemented to prevent hypothermia. Even if one intervention is not done appropriately, there is a possibility that baby can become hypothermic. So then we looked at the baseline data. So this is the perfect example of a run chart. As opposed to other statistical methods, run chart basically gives a visual description of the entire process over time. So typically in all QI methodologies, we would be using run chart because it will show the ups and downs over time. So here in y-axis, we have the baby temperature, and in the x-axis, we have the baby numbers jotted. We can see the median line, which again shows most babies are hypothermic, and then there are a lot of fluctuations. So then we drew the fishbone diagram. Fishbone diagram gives us an idea of broad overview of what are the processes which can go wrong and can lead to hypothermia in the baby. It can be with the various materials we use, the processes or methods we follow, or the people, or the various equipment, problem with the equipment. So there are so many things. Which one do we correct? So for this, we use the Pareto chart. So here in Pareto chart, when we observe 10 or 20 deliveries, you note down what are the deficiencies in each of these 10 or 20 cases, and then plot it over a graph. So if you see here, if you address 3 things, 80% of the problem can be solved. What are the 3 things? Proper application of plastic wrap. Have role assignment during delivery, make proper equipment check. So 3 things among all those features, if we address, majority of the problem can be solved. So in the first PDSA cycle, we thought the plastic wrap application is faulty. Why not we use these plastic bags? So, and then we taught people how to receive them and how to transport baby in the NICU. And then again, we did the run chart. As you see here, again, majority of the babies were still hypothermic. Our median did not change. So then we went back to the residents, asked their feedback. They said these bags are very stiff. They are open at both ends. They are not doing. Then they gave the idea of why not spread it over the panels of the radiant warmer, and we will try to cover the baby well. Second, we also realized that the nurses in the labor room, they were not at all aware. They have not been taught what is this QI, why we are doing this, and how they can take part. So peer-to-peer teaching works out very well. So we called in our NICU nurses and we made them to teach the labor room nurses and educated them. And then we drew the run chart again, and then we were very happy to see a blip here, the increased temperature. So these change ideas were adapted. So in phase 3 PDSA cycle, what we made sure was to implement the other aspects of the bundle. We installed a thermometer in the labor room. So this made sure that the nurses would not run the ACs. They would switch down when the baby was about to be delivered. They would keep a track of labor room temperatures to be 25 degrees and above. We sought the help of our ancillary workers. We coordinated with them and made the transport incubator to be plugged in, pre-warmed and transport. And we also made a very warm reception. Even before we went for delivery, we would keep a bed ready, keep the baby linen warmed. So this also helped. In the post-intervention cycle, it was mostly of motivation, giving visual progress to all the stakeholders. This gave them motivation. Whenever there was a baby with hypothermia, we would do a root cause analysis, try to see what went wrong with each case. And we also address the logistic issues. So this particular chart is a process control chart. Here you can see a stepwise increment in the mean temperatures. These upper and lower red lines, they correspond to plus or minus 3 standard deviation. So without doing elaborate calculation, these run charts and process control charts would help us to understand whether the process is improving over time and whether the process is stable. If all the points are within the 3 standard limits, then it indicates a stable process, which will only alter to changes that we make in the system. So we also noticed that the incidence of moderate hypothermia fell significantly from 50% to 12.5%. And to sustain this change, we made certain changes to the system itself, which made that we made a delivery room checklist so that all equipments are checked before each delivery. The thermometer was in place. Nurses made it a routine to monitor the delivery room temperature, and we made admission temperature as a quality indicator, which means that each and every baby who gets admitted to the NICU, the consultant makes it a point to note down and discuss during rounds if the baby was hypothermic. And we continue to use run charts for feedback. So we went on to publish this particular QI as well as various other quality improvement studies that we did in NICU during that period in this particular article, which is a part of a supplement in Indian pediatrics. Then we also, this gave us confidence because it is an easily pluckable this thing. We could see the results within our own eyes. So we went on to do more complicated projects. You can see that we did this target oxygen saturation among preterm neonates. Again, this is published. And then when I worked subsequently in JIPMER, we did 2 more quality improvement projects. One was to improve the voluntary milk donation that they would do in a milk bank. The other one was the involvement of parents, family-centered care in the NICU. So these were very fruitful projects, and then these would be published also. Another thing to note, in many of these publications, you would see the nurses' participation. For example, in this QI milk bank project, so other than myself and the consultant, the others are all nurses and the milk bank staff. So that gives us more joy also. Thank you so much, sir, for this wonderful opportunity to share the QI with newborns.
Thank you so much, Sindhu, for sharing that and a crisp presentation. I think what again Sindhu highlighted, that once you start looking around and start measuring, you are surprised to see problems. So like she said, we were surprised to see hypothermia happening so commonly. You know, I am reminded of our project on the similar lines as Dr. Akshay presented, that we said, okay, when you diagnose sepsis, how quickly the first dose is administered? Is it being administered within first hour as per the guideline? And we found virtually in 0%, no baby actually got within first hour. Till we intervened and did a stepwise QI, and we found, okay, we can do it. So it's important to look around, listen to people, and try to objectively measure and see what is really happening. What Dr. Sindhu showed that, certain things as part of the POCI methodology. So she showed us clearly, if you are planning an improvement project, write a SMART aim. So unless the aim is SMART, specific, measurable, relevant, timely, and achievable, the project may not succeed. And then she also showed us a simple way how the data can be displayed. Not only it can tell you whether you're improving or not, it can be used to motivate other people and communicate. So, if you can put up a poster or a printout, anybody walking around can see, okay, this unit or this department is working on improving this item, and this is how they are, and then some people may come and give you more ideas. See, this is how you can do it. And I think the chart is actually very simple. Maybe your children in class 8 or 9, they can make a, a graph paper or a computer. But she also showed the beauty of PDSA cycles. We have been listening to all the speakers' PDSA cycles. So it's important to test your change idea through the PDSA cycle. It may sound very logical that you change this and it is going to work. But in real life, it may or may not work. And she gave us examples how making small changes, testing them, and tweaking them if required, or abandoning them if they don't work, it's critical to reach a conclusion that what works and then make a policy. The mistake all of us make is, we presume things will work and we announce a policy. We issue a circular or a guideline without actually testing on the ground that it will work or not. So again, beautifully illustrated through Sindhu's presentation. So thank you, Sindhu, for the wonderful presentation. I don't see any question at the moment. Just a second, let me check. Yeah, not at the moment. We'll come back to you maybe later on if there are questions. So with this, we'll move on to the last speaker of the day, Professor Deepak Chawla. So Deepak, if you can share your CV slide. Because you heard in the beginning that we are residents, we have to do thesis. So it's often a challenge. You give a QI project as a thesis. The resident thinks my other colleagues are doing a randomized trial or maybe cohort study and they will be able to publish at present. Will I be able to publish or not? So Professor Deepak Chawla is Professor of Neonatology at Government Medical College, Chandigarh, and again, very tech-savvy, computer expert person, and very, very methodical, great teacher, and a lot of experience in QI for more than a decade now. So he's going to share with us that if you want to really publish your QI work, what should be the standardized format so that right from the beginning, you work on those lines. Over to you, Deepak.
Good evening, sir. Can you see the slides and can you hear me? Hello?
Yes, sir.
Okay, thank you. Thank you to the organizers for giving me this opportunity to present this small talk. So over next around 15 minutes, we'll try to understand how to publish QI work. And I think before we start with how to publish, one important question to ask is why to publish at all. So apart from improving the care of patients, which is the obvious reason that we conduct QI, there are two major reasons to publish QI work. First, it is to disseminate the results and methods to others. As Dr. Aparna said, there is no plagiarism in QI. If someone else has done QI work and if you see it and it shows that improvement is there, you can directly adopt these changes and say that we have copied their results and achieved the improvement in our scenario. So obviously, after improving care of your own patients, you can disseminate the results to others and others can see and adopt your results. And then second benefit of publishing QI work is the academic career benefits. As Dr. Akash, Dr. Aparna, Dr. Parijat showed, they had multiple publications from QI work. And publications are publication, whether it is from a randomized control trial or a QI work. So it promotes academic career in selection, promotion, in filling your ACR sheets every year. So it is helpful in this front also. Now, what we learn here is what are the components of a QI manuscript, how it is different from research paper, and what are reporting checklists available when you are trying to write and publish a QI work. Now, a QI work is like a journey. All of us are traveling, and with us, our units, our departments are traveling. Many times we do not know where we are going, but nevertheless, we are traveling. And when we try to do a QI work, we try to choose a different path. That instead of going to the usual path, we are going to change the path, try to reach some place which is somewhat better. And most of the time, at present, at least when we initially start doing QI work and we are looking at low-hanging fruits, most of the time we are successful in getting to a better place. So publishing QI work is to write that chronicle of your journey, that how you traveled, where you reached. So this is QI work is just, when you publish it, it is just describing the journey of QI QI march, which you did from start to the end. So when you do this journey, what do you describe? You describe who are you, where do you intend to reach, why did you choose this particular path, how did you move along this path, how did you overcome the barriers on the way, and did you really reach a better place? So you have to describe this, your journey, QI journey, along these lines, and we'll try to look at all of these points. Now, first of all, you have to describe who are you. And here, when you say who are you, I want to say what QI project you chose, what was that choice, and what is the context of that problem. These two are very important. So when you're doing a QI work, initially, I think all of us are focused on improving the evidence-based practices for routine care and management of illness, like giving antibiotics earlier, reducing hypothermia, attending to patients in emergency earlier. So this is all evidence-based practices. But there are many other aspects of QI, including improving actionable information system, improving referral system, improving communication, improving respect, privacy of care. And then the persons who are working at higher posts like medical superintendent or deans to improve education or improve physical resources. So there are many domains of quality. And when you publish your QI work, you emphasize you are looking at what particular domain. At present, most of us will work on evidence-based practices, but it may change and you need to highlight what is your focus. And then the describing context is very important. Within India, there are many types of healthcare facilities, public, private, and within public, there are many different systems of work. And you need to tell where you are working. So if you take an example, most of the examples which I will show are from Indian QI work. So this is why you choose to, what is the choice of QI work. So these authors are saying, in our unit, the usage of expressed breast milk in infants was low and proportion of EBM usage of total feeds was only 52%. And the availability of first EBM after birth was often delayed for days. This prompted us to start a QI program in our hospital. So you can see the authors are trying to justify the choice of their QI work. And here, another project from India, the authors are giving the context of the QI problem. So giving this context is very important in QI work, because this QI work people are going to adopt and they need to know in what context this QI work was done. So here, the authors are describing where they perform the work. So the SNCU is a typical 20-bedded government-funded level 2 unit, staffed by 4 doctors, 20 nurses, sharing of bed is there, single doctor is there. And what type of patients are there? Premature baby, low birth weight baby, respiratory distress baby. What type of burden is there? 3,000 sick babies per year, of which 65 to 70% need oxygen. So this gives a context where this work was done. Now, once you started the journey, next you need to tell where did you intend to reach, and that is from AIIMS statement. You get the SMART AIIMS statement as S.Sindhu presented in the work, and Praveen sir highlighted that your AIIMS statement has to be specific, measurable, achievable, relevant, and timely. You have to tell what is your aim, what was your AIIMS statement. And again, these are examples from 2 different studies giving AIIMS statement of the work that to obtain EBM in more than 80% of very low birth weight infants within 48 hours of admission to an ICU, improve volume of EBM in first 48 hours by 100%, to decrease the time of availability of first EBM by 20% of baseline, and to improve the proportion of EBM by more than 20%. And the second one had to reduce the oxygen consumption from 8 cylinder per day to 4 cylinder per day, that is 50% reduction within 8 weeks. So these are the smart aim statements which the manuscript has to provide. Then you have to describe why did you choose the path. You have to justify that what study design you chose and why you chose the study design. Most of us are, if you start reading QI work, most of these are before and after studies in which you do a PDSA cycle and you show that before your PDSA cycle, the situation was somewhat here. And for example, these are the hypothermia incidents, and with QI work, you did your QI work, PDSA cycle, and the hypothermia incidents decreased over the period of 8 to 12 weeks. But there are many other possible study designs like controlled before and after design, interrupted time theory design, cluster randomized trial, or stepwise cluster randomized trial. So these are different types of study designs which are possible. And if you are done choosing a particular study design, for example, before and after, you should be clear that you have chosen this study design, why you chose the study design, and you give the study design properly in the manuscript. Then second part of why did you choose the path is to perform and present the analysis of the problem. So there are different ways of analyzing the problem. 4 main ways are having a driver diagram, having a fishbone diagram or root cause, having a process flow chart, and having a Pareto chart. So these are 4 examples taken from 4 different studies conducted in India, published at different times. And your manuscript has to have at least 1 or 2 of these analyses, because this tells the reader that you have performed a scientific analysis. Your change ideas were not your spur of moment or just your own brain ideas. You conducted a systematic way, and actually improvement is all of us try to improve in day-to-day practice. All of us do improvement, try to improve. Only thing with QI is that it is a systematic scientific approach, and that one part of that scientific approach is analysis of the problem. And the manuscript has to have this analysis of problem presented both in text format and in these charts, which are very useful. So typically, you will look at least a fishbone diagram or driver diagram. At least one of these 2 should be there. And if needed, a process flow chart and Pareto chart can also be added to a manuscript. Then once you started your journey, how did you move on the path? And this process of QI is also very important. It is not only important to tell that I started from this particular place and then reached this place. I reduced the incidence of hypothermia from 70% to 10%. That is not all. That is not the complete description. You have to tell the process how you reached from 70% to 10%. What all QI activity you did. Maybe there was multiple PDSA cycles, and the choice of dynamics of PDSA cycles are not predefined. Why you choose a PDSA cycle and how that PDSA cycle worked. Not all PDSA cycles are successful. So even if a PDSA cycle is not successful, you have to describe it. So it is important to collect and report not only the outcome data, but also the PDSA data. So a PDSA table, which then tells you that what all PDSA cycles were done and what was aim of that PDSA cycle, what was planned, what was done, when it was done, and what was the analysis of that PDSA cycle, what all changes were tried and whether those changes were successful or not, and whether those changes led to improvement in your smart aim or not. So this process of QI, which is described in a PDSA cycle, has to be collected. Many times we forget to collect it, and then later on when you start writing manuscript, it becomes very difficult to go back, and you have to maybe rely on memory of everyone that what we all did in different PDSA cycles. So if you plan it beforehand, then you can collect all this data and present it systematically. And many times there are multiple PDSA cycles. So this particular work has maybe 10 or 12 or 15 PDSA cycles. So it is important to collect data of every PDSA cycle so that you can present it in a graphical and tabular format. Then it is and there are many comments for also there that once you start QI work, you will have barriers. People will not agree to QI work, or you will have structural barriers, physical barriers. So this is similar to a journey. When you start your journey, you will have potholes, you will have roadblocks, you will have trees falling on the road, and you have bridges collapsing, you have VIP movement, which is interfering with your journey, and if nothing else, cows sitting on your road, which are blocking your journey to the QI path. So everyone will encounter barrier, and your manuscript has to tell what barriers you encountered and whether you were able to overcome. If you are able to overcome, how you overcome that barrier, because everyone will have these problems. And so describe this. How to describe this? You can describe this in the form of a case study that while we were doing this particular pediatric cycle, we had this type of problem, and how you handled this and whether it led to improvement or not. Or you can describe it as a challenge. So this is another example from work done in PHC, that what challenges were there. Budget stopped or transferred happened. You trained someone and those persons were transferred, nurses were transferred, or they went on strike. So these things happen, and you have to describe all these challenges as part of your QI work. Then lastly, you have to prove that you reached a better place, that your work led to actual improvement. Now, it is easier to prove with a control arm, that you had a control arm and a intervention arm. In intervention arm, you did your PDSA cycle. After PDSA cycle, you had improvement. But as usual, if it is a before and after study, there is no control arm, then you have to take extra care that if you had improvement, then whether that improvement is just because of time, that with time you are improving. So you like it is said, with rising tide, every boat rises. So whether your boat has risen just because the tide has risen, you have to disapprove that this improvement is not just because of time. So, and whether the improvement is not because of your PDC cycles, but it is because of external factors, that some extra program was started by a government, or you got extra staff or extra residents, that led to improvement. So, and the way to do is to collect data not only during the PDSA cycle, but also before, to show that the trend was not showing improvement before, and only once you started your QI work, only then improvement started. And then show relationship between change ideas and improvement, like I will show in the next slide. So these are two examples of two different control charts. In first control chart, you see that, for example, this is slender use. It has come down from 8 to 4, but it is not showing what all changes were done on the way. While if you look at the second one from S.Sindhu's paper, you see that there are changes happening, and these changes are then illustrated on the sheet, so that you know that with this change, improvement happened. With this change, this happened. With this change, this happened. So illustrated control charts along with the data of PDSA, which I said earlier, these will convince people that the change ideas which you did actually led to improvement, and the improvement was not just secular trend or external things which helped you in achieving the improvement. And then I will not go into detail of this, but these are various ways by which control charts show whether shift is happening, a trend is happening. So it is important to be conversant with these rules of interpreting control charts. And control charts are not the only way to collect the data of quality. There are 6-7 different types of charts. Once you start looking at quality work, then read more and more about how data of quality, different types of variables are collected, and how these can be presented. Because if you are trying to publish, you should know that what type of data I have collected and what type of chart will be most appropriate for this type of data. Lastly, like there is consort checklist for reporting randomized controlled trials. Most of you must be aware. Similarly, for quality improvement, there is square checklist, currently second version. So this is standards for quality improvement, reporting excellence. And these are 17, 18 items are there. And once you start writing, look at all whether you are fulfilling all these reporting checklists. So there are checklists for titles abstract, for introduction, for methods, for results, for discussion, and for other information. So as I said earlier, there are many things which I have talked about, like describing context, how the data was collected, how analysis was done, and analysis of contextual elements, unintended consequences, missing data. So all this has to be reported in your work of the quality improvement. Thank you, sir.
Thank you so much, Deepak, for that wonderful presentation and really making it, simple, converting the technical part from square guidelines to kind of non-technical, so that we all were able to understand what are the steps to be taken. And I think Dr. Deepak made a very important comment, because one of the goals of publishing QI work is that other people can learn from your experience. Now, they can only learn if the description is has sufficient details. And luckily, the QI journals are liberal with the word limit. They are not very strict. So they do want that you describe everything, what happened, how you overcame the challenge, etc., in great detail. And this can only happen if you are maintaining your PDSA charter document side by side. Because by the time you start writing, many things are forgotten. They are just, faded in the memory and after several months. So the PDSA charter document template, which Dr. Aparna had showed you, which is freely available on the website, you can download, and in each PDSA cycle, make sure somebody is documenting, writing in great detail that what changes, because sometimes people are unable to even recall what change they made. It's difficult. So it's always good to keep noting down and then describe that in detail. So thank you, Deepak. That was really wonderful presentation. I think this will help all our residents or everybody who is embarking on this project, that how they can publish their work and get credit for that and share with others. Now, before I summarize, there are a couple of questions, one for Dr. Deorari and then for Dr. Akshay. I would request them to answer that. So Dr. Deorari, there's a question for you. How should we create the benchmark? Should it be individual or global benchmark? Like, what should be the goal or target for improvement? How do we decide?
So I think you have to be a little bit realistic whenever you want to decide your goal. First, you need to have your baseline data information. And then from that, you have to make a realistic goal, how much you want to improve over how much duration. If you improve much more, is another feather, good thing you have done in the QI work. But at least you must have a benchmark. You can't have something improving from a baseline of 30% to 100%. So have a goal which is realistic goal for making it.
Thank you. Very, very important. And Dr. Akshay, you mentioned about kind of minimizing the change of nurses and maybe even hospital attendants in the emergency setting. So people are interested to know, like, how did you manage to do this? Because this is a problem in all the hospitals. You go in the morning, there's a new face. Come in the evening, and next day there's a new nurse. And the bed assignment also keeps changing randomly. So how did you achieve this, Akshay?
So I don't see him in the meeting.
Yeah, but I can only make a comment that I think since the nursing administration is under the, a different, so you have to obviously involve them. And once nurses are involved in your team, you interact with the administration, give reasoning why, a change is detrimental to patient outcomes, how it will help the nurses themselves. So they would agree. And I think, at least in AIIMS PGI, we have been following this model of, in fact, in our units, if a change is going to be made, we will be informed beforehand that we want to change X person. Can we change the nurse or not? And this is not like any kind of fear. This is simply a camaraderie and over the years which has come up. Maybe Dr. Deorari can comment on this issue.
So I think if the nurse leader there or the CNO knows that your team is doing a good work, they normally will not change the nurses. The same nurses will stay. But if they are not aware that good work is happening at that place, they will keep on changing the people. So that also is very, very.
More question, which I think I can answer. So one is, can we use QI in managing antimicrobial resistance? And if yes, what can be the key performance indicators for the same? Yes, definitely it can be used. And at least in our place, we had a project running for 3-4 years. Dr. Somashri Ray from Calcutta, when she was doing her DM, did this, and we tackled several issues related to antimicrobial use as part of antibiotic stewardship using QI approach. And same thing we have done in Madhya Pradesh SNCUs, where the usage of antibiotics came down dramatically. And I think this publication you will see very soon. So you can focus on initiation of antibiotics, whether people are using unинdicated antibiotics. You can focus on whether blood culture is being sent prior to send, for example, Akshay showed in emergency. Then you can focus on timely stopping of antibiotics, especially in the culture negative cases. That unnecessarily everybody is not getting 1 week, 10 days empirically. So can I stop early? You can focus on the use of carbapenems or colistin or vancomycin, higher generation antibiotics. So all these can be metrics. You can use some standard metrics about antibiotic consumption, like especially newborns, we use days of therapy, but in adults, the triple D, daily dosage, WHO recommend, that can be used. There is a document by CDC on antimicrobial stewardship, which gives all the metrics, how they can be measured, and one can choose from that. For newborns, we recently published the clinical practice guideline on antibiotic stewardship from National Neonatology Forum. And in that also we mentioned what kind of matrix can be used in the neonatal setups. So definitely this is an important modality to decrease antimicrobial resistance, and this approach can be used and metrics are available. One more question is about, is POCI only for mothers and newborns?
Oh, it is for infants, children, and everywhere. You have seen in ER, you have seen in different places it is getting used. Actually, all the methodology of QI are more or less the same. And the aim is for doing improvement. Sometimes you will find PDSA is written as PDCA and they will name it differently. So methodology is same. Indian version is a simplified version, which is contextualized, piloted, used many times. Okay, once you start using it, you can do more of QI by getting into driver diagrams, doing collaborative projects. So those are higher levels of QI. And if you get interested into it, you will walk that path.
You can use not only in all healthcare departments, you can use it outside. You can use in your teaching, day-to-day teaching you're doing. And you will see some discussion on this in the upcoming medical education conference in Bangalore, that how you can use QI approach to improve your teaching methodology and the effectiveness of that. And I think you can use QI on yourself. I think rather that should be the first step. Like look at your health habits, whether you're doing exercise, are you eating proper diet, how is your own behavior, how many times you get angry per day, how many times you shout on residents, nurses, how are your relationships with colleagues and seniors and juniors. So I think you should first attempt your QI on yourself. If you do that, you will realize it's not so easy to change. I think I should get up at 5 a.m. like Dr. Deorari and go for a walk, but I'm unable to do for so many years. So there is a large gap between what I wish to do and what I'm able to do. Once you realize that, you will not complain that my colleagues are, their behavior is different. They are not accepting the change. They want to change, but it's difficult to change. There is immunity to change. And so you have to find ways and means of changing the system in such a manner that people automatically will start doing the right thing in the easiest possible manner. Make it easy for them to do the right thing.
I mean, there is an excellent book which is called as Kaizen, the Japanese method for transforming habits, one small step at a time, by Sarah Harvey. It's a wonderful book. One should read that book every day, 16 pages before you sleep. Then you will know how improvement can be done for yourself and then in your healthcare also.
Thank you, sir.
Kaizen.
Yeah. So I think if I were to summarize all the presentations today, so what we saw was a glimpse of excellent work from at least 4 different specialties, 4 different departments, and how not only they have done QI projects, how they have changed their culture over the few years, how they've taken everyone together, the frontline workers, residents, nurses, And now it is more or less an auto mode that people are doing QI, they are looking for opportunity. And they showed us a lot of learning that to solve a problem, you have to be systematic. And POCI is one model which you can use, but you can use Kaizen or any other system. And like you treat a patient, that patient comes to you with a history, you make a physical examination, you make a diagnosis, then only you give treatment. So similarly, we have to make a system diagnosis before you give the treatment. So the treatment is a change idea, but before that, by using the fishbone or process mapping or Pareto, you find out what are the causes, underlying reasons why a particular quality gap is there and what I can do. And I think all these presentations also taught us many unsaid or unwritten things. They didn't say, but I could see, they talked of leadership. They gave us examples of teamwork, collaboration, open-mindedness. So all these are required if you want to really do successful quality improvement. As far as MD thesis is concerned, I remember when you initially call the MD resident and tell them we will do a thesis on this, the resident talks to fellow colleagues who are doing different kind of research and gets very worried. Sir or madam is telling me to do this, how will I publish? How will it get completed? I don't understand anything. But by the time they complete, they are transformed. They are so much satisfied that they did actually excellent work, rather than simply doing a case series or some ill-planned cohort or RCT, which is called a wasteful research and waste of time, which will not add to anything. Whereas this way, people are able to make changes, make impact, and they feel very, very satisfied. So I think this is very important to involve these people. And as I mentioned, there was a question also, even in the resource constrained settings, instead of worrying about less of manpower, less of resources, you can do a lot of QI stuff by eliminating waste, by eliminating redundant steps, simply changing few things, and get a lot of satisfaction in that. So with this, I would like to thank all the presenters for sparing their time and sharing their experience. And of course, Dr. Deepak Chawla for making it simple how we can publish. And of course, the team at Himalayan Institute of Medical Sciences led by Dr. V.Chauhan, Dr. Deorari, and Dr. V.Chauhan. So I hand it over back to the organizing team.
Thank you so much, sir. Thank you, Praveen, sir, for being with us throughout the session and summarizing it so beautifully. You were simultaneously also taking up questions. This was, the gratitude is all that we have for you and for being there with us all the while. And we want to put on record our thanks to all the faculty members who took sessions here. Despite all their limitations, someone to catch a flight. You were yourself in the interviews, as Dr. Anu told me. So thank you once again. There were so many aspects like emergency medicine, nursing, community setting. We came to know about the processes and how to document them. Thank you all. We also want to put on record our thanks to the team here at AIIMS, Mr. Mukul and Mr. Tarun, who were there for the IT support, Dr. Aarti, who was constantly giving us an update on the questions, Dr. Deorari, sir, for being the inspiration behind us, and Dr. V.Chauhan, sir, for supporting us for all causes. Thank you so much. I hope I have not left out anyone. Dr. Parijat, your success stories were great. We would like to emulate them sometimes. Dr. Deepak, thank you for those wonderful narrations that you made. Dr. Aparna, hope you catch your flight well in time. Thank you. Dr. Deorari, sir, would you like to say something before we finally?
So I think this has been a wonderful session. There has been huge learning for me also. See, you learn a lot of things. So those of resident doctors and faculty who missed, I think they will have the opportunity of going through the YouTube link, which will be there. Many more people will be benefited out of it. And whatever you do, you have to publish it. You also know now how publication can be taken. So thank you once again, Praveen, Deepak, Akshay, Aparna, Parijat, Sindhu, everyone, and Juhi and Chauhan sir for sitting through the entire. It's going to be now 3 hours since we started. So it has been fruitful session. Thank you so much.
Thank you, sir.
Thank
Dr.
you.
Chauhan sir, आप कुछ बोलना चाहते हैं?
कुछ बोलेंगे sir?
Thank you. It was really a wonderful and eye-opening session for all of us. How small steps can change the whole environment and the culture in improving the quality. I think these stories were heart-touching stories, I can tell you. The real stories, few people have worked on them, and we need to emulate them. I think if we adopt these small measures in our lives, our working would become good, and finally, it is the patients who will be benefited. So I think we need to thank all the speakers. They really spend their energies and time in illuminating all of us. And my special thanks to Professor Praveen Kumar from PGI, who has beautifully summarized and moderated this session beautifully, I think. It was inspiring for all of us to hear all the speakers. All the speakers have touched us, I tell you. And it speaks that they have a passion about quality. And those institutions who don't practice quality, I think, would perish in future. I think we all need to emulate these small things which we have learned today. And it was a great learning for all of us. And I'm sure if it's a learning for us, all the participants who participated must have imbibed something good today in these sessions. All the speakers made things so simple and so lucid. Believe me, even a layman could understand. So thank you very much, all the speakers.
Sir, I think we need to meet them physically someday.
Yes, because I think this session would have been wonderful.
Enormous energy.
We need to invite them personally here. All of them.
Enormous energy, which is infectious.
Yes.
A lot of people.
I'm stimulated. I'm stirred. I tell you.
Thank you.
Wonderful session. Thank you.
Thank you. Thank you, sir. We sign off.
Thank you.